My life is better ever since he kissed my lips.
ARVs, 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 my real lover. He's dependable, energetic, reliable, my real lover. He came and gave me PMT City.
My kids are healthy, jumping and clapping so good. They're full of life,
Hope and energy.
millions of people in every nation dying.
They are
To taste
his charming company. ARVs, 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 my real lover. Is dependable, energetic, reliable. Listen, you want a country free of the violence. Listen now. You got to treat everybody tested positive. Zero infection, zero mortality, stigma down. You got to involve people with HIV and no isolation, no discrimination. Daily, you got to treat them good and equally. ARVs, 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 my real lover. Is dependable, energetic, reliable, my real lover. ARVs, 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 my real lover. Is dependable, energetic, reliable, my real lover. ARV, my real lover. Thank you, thank you. Hey, stay. Tuchabawa. That's a song called Real Lover. Why do we sing about this lover? The whole world, we have 37 million people living with HIV, and they all depend to that one real lover we have just talked about. Without that real lover, the 37 million people living with HIV globally would be dead. Therefore, you can tell the importance of our real lover. You can see the reason why we sing about our real lover. ARVs bring a good life to people living with HIV, but it also has other importance, like the prevention. PMTCT basically depends on ARVs. For a mother not to infect a child, she has to use an ARV. A negative person, you don't want to get HIV, you are given exposure prophylaxis, is an ARV. You're a negative person, but you have just been exposed. You have been raped. Your condom blew when you are having sex with a person and you are scared. Maybe the person has HIV. Immediately before 72 hours elapsed, you see a doctor. He gives you PEP, post-exposure prophylaxis, which is an ARVs. Therefore, when we sing about ARVs, we mean it. It's our real lover. The next song, ladies and gentlemen, I want to give you, it's a song we did in partnership with Evnt, and it's called Hear Her Cry. We are fighting gender-based violence too, because it's also another cause of HIV infections. Girls are being raped. Girls are being forced into sex. Girls are being abused, causing new infections. Gender-based violence. Give the song, Hear Her Cry. With Evnt. Hear her cry. Hear her cry. This voice is calling you for the rights of young women and girls. Tetuba tulugunya nabo bantu tubalekere bambye dembe lyabwe. Hear her cry. This voice is calling you For the rights of young women and girls, tetuba tulugunya, nabo bantu tubalekere bambye dembe lyabwe. Hear her cry. Uganet say, tubadde kyabami, lwaki tweyisa ng'ensolo, okutulugunya omukyalo oba omuwala, ekyo kiva ennyo. Musange wa Katonda ne mu kkooti gwanaggomola, omwana gw'otulugunya, ficha yo gisudde mu nnyanga kikomye leero. Gwe kikomye leero. This voice is calling you for the rights of young women and girls. Tetuba tulugunya, nabo bantu tubalekere bambye dembe lyabwe. Hear her cry. This voice is calling you for the rights of young women and girls. Tetuba tulugunya, nabo bantu tubalekere bambye dembe lyabwe. Hear her cry. 6,000 ab'obuyinza mu ggwanga n'abazadde muwulire bino, kibakakatako okuguusa gabava yonna gy'obeera. Temubikkirira misango, mubatwale bawozesebwe. Va mu kulya enguzi, bulamu bwa muntu bw'ozannyirako, kikomye leero. This voice is calling you for the rights of young women and girls. Tetuba tulugunya, nabo bantu tubalekere bambye dembe lyabwe. Hear her cry. This voice is calling you for the rights of young women and girls. Tetuba tulugunya, nabo bantu tubalekere bambye dembe lyabwe. Hear her cry. This voice is calling you for the rights of young women and girls. Tetuba tulugunya, nabo bantu tubalekere bambye dembe lyabwe. Hear her cry. Hear her cry. Did you like the song? Did you like the song? Hey. How to scientific. Thank you so much. The chair has taken the seat. I think we can. Hey. Thank you so much. Thank you so much, Uganda AIDS Commission, for organizing this.
Allow me welcome everyone to the 14th Annual Joint AIDS Review and the Lutaya Memorial Lecture. We should be getting started at 10 o'clock, but I would like just to welcome all of you to this meeting and thank you very much for putting aside time to join this great event. Meanwhile, we shall continue with some entertainment. We have quite a number of people already online, and I want to extend a warm welcome to all of you who are with us online. And similarly, we have a number here who are attending this meeting physically. It is a pleasure to receive you here. Thank you. I think let's continue with some entertainment as we wait for 10 o'clock when we shall be starting this meeting formally. Thank you.
Close your eyes and not go to sleep. Did you notice the sunset the first time in ages? Speak to some stranger on the street. Did you lay down at night, think of tomorrow, go out and buy you a gun? Did you turn off that violent old movie you're watching and turn on I Love Lucy reruns? Did you go to a church and hold hands with some strangers, stand in line and give your own blood? Did you just stay home and cling tight to your family? Thank God you had somebody to love. I'm just a singer of simple songs. I'm not a real political man. I watch CNN, but I'm not sure I can tell you the difference in Iraq and Iran.
The Candlelight Memorial Day is an internationally recognized day. It is done to remember all of those people who have died because of AIDS. People who have died because of AIDS, need to be remembered so that we stand in solidarity with the ones who are left behind, their relatives, their loved ones, their employers, because of the great work they have done. So we commemorate it every 17th day of May of each year. This year, because of the multiple events happening in the country, this had to be postponed to the 27th of May. But individual institutions, commemorate this. It can be at a workplace, it can be at family level, and you do that by lighting a candle, signify that we still remember you, we still love you for what you did, and it energizes us to continue with the fight against HIV and AIDS.
Let's light the candles and sing in harmonies to remember people who died because of HIV. Jine misubawa, jitante kone sala, yonna bigende, edibana fababazawa. Let's light the candles and sing in harmonies to remember people who died because of HIV. Jine misubawa, jitante kone sala, yonna bigende, edibana fababazawa. Struggling every minute to accept the truth that you have gone. Staring at the children you left behind, poor kids. You left this world like rays of departing sun. Memories of your smile created big cracks in our hearts. Let's light the candles and sing in harmonies to remember people who died because of HIV. Jine misubawa, jitante kone sala, yonna bigende, edibana fababazawa.
Stained windows sparkle as the sun is shining bright, but they end up losing beauty when the darkness falls the earth.
The bitterest tears we shed were because of losing you. UNESC Lord, salute you for the endless fight you gave. Let's light the candles and sing in harmonies to remember people who died because of HIV. Jine misubawa, jitante kone sala, yonna bigende, edibana fababazawa.
Tunajjukiranga obulamu bwe mwayitamu, tunaabasabiranga kubanga mwali balwanyi, obubaka
Attention,
obwaleeta mukole nnyo mwekuume eggwanga libeetaaga nnyo.
Let's light the candles and sing in harmonies to remember people who died because of HIV. Jine misubawa, jitante kone sala.
For breakfast for 20 minutes so that we are here at 10 o'clock ready to start, and thereafter we shall just run through to lunchtime. We hope that this will be time saving. So let me invite the chairperson Uganda AIDS Commission to lead everyone here for breakfast. Meanwhile, the music and video should continue for our online our participants. Thank you.
The Candlelight Memorial Day is an internationally recognized day. It is done to remember all of those people who have died because of AIDS. People who have died because of AIDS, need to be remembered so that we stand in solidarity with the ones who are left behind, their relatives, their loved ones, their employers, because of the great work they have done. So we commemorate it every 17th day of May of each year. This year, because of the multiple events happening in the country, this had to be postponed to the 27th of May. But individual institutions, commemorate this. It can be at a workplace, it can be at family level, and you do that by lighting a candle, signify, that we still remember you, we still love you for what you did, and it energizes us to continue with the fight against HIV and AIDS.
Let's light the candles and sing in harmonies to remember people who died because of HIV. Jinemi subawa, jitande konesala, yonna bigende, elibana fababazawa. Let's light the candles and sing in harmonies to remember people who died because of HIV. Jinemi subawa, jitande konesala, yonna bigende, elibana
Struggling every minute to accept the truth that you have gone. Staring at the children you left behind, poor kids. You left this world like rays of the pouting sun. Memories of your smile created big cracks in our hearts.
Let's light the candles and sing in harmonies to remember people who died because of HIV. Jinemi subawa, jitande konesala, yonna bigende, elibana fababazawa.
Stained windows sparkle as the sun is shining bright. By the end of losing beauty, when the darkness falls the earth.
The bitterest tears we shed were because of losing you. UNES will always salute you for the endless fight you gave.
Let's light the candles and sing in harmonies to remember people who died because of HIV. Jinemi subawa, jitande konesala, yonna bigende, elibana fababazawa.
Tunajjukiranga obulamu bwe mwayitamu, tunabasabiranga kubanga mwali balwanyi. Obubaka obwaleero bwammwe abavubuka, mukole nnyo mwekuume eggwanga libeetaaga nnyo.
Let's light the candles and sing in harmonies to remember people who died because of HIV. Jinemi subawa, jitande konesala, yonna bigende, elibana fababazawa. Candlelight day, this is candlelight.
Candlelight,
Candlelight day, no candlelight.
candlelight.
Candlelight day, this is candlelight. Candlelight day, no candlelight. Candlelight day, this is candlelight.
Candlelight, candlelight.
Candlelight day, no candlelight.
Candlelight, candlelight.
Candlelight day, this is candlelight. Candlelight day, no candlelight.
Candlelight.
Candlelight day, this is candlelight.
Candlelight. Candlelight. Thank you.
Okay, so there are important messages that I would like the people of Uganda to know as we commemorate the Candlelight Memorial Day. First of all, that HIV is still here with us. That although we have treatment, it is not a cure. We do not have a vaccine. So we still need to protect ourselves and keep ourselves, because the risk of catching a new HIV infection is still there. That is one message. The second message is that we still see a lot of stigma due to that people living with HIV experience. And this stigma may be in homes, from the people they live with, either their parents, their siblings, the caretakers. The stigma may be in schools, from their teachers and schoolmates. It may be at the workplace. In fact, this year, the theme for our commemoration is ending HIV stigma at the workplace. You know, we would like, because we know, and the workplace extends beyond just, you know, the office environment between the two walls. The workplace could be in a home. You know, if you have house help, that is their workplace. That is, if you had, you know, somebody living with HIV, and he also works, you know, as the housemaid or the nanny, whatever the name will be, there are reports of lots of stigma and discrimination. So we would like Ugandans, I would like Ugandans to know that people living with HIV should not be judged by their condition. That they are like anybody else. They are capable of, you know, doing things that all other people do. Many times even better than, you know, how the other people are doing. You know, when they are put in school, they perform better. We know of doctors, lawyers, teachers who are excellent in their work despite their HIV status. When we discriminate these people against and stigmatize them against HIV, it has many effects. They lose self-confidence. They may not go to access, you know, HIV services, including testing, including treatment. And that not only puts them at risk, it puts other Ugandans at risk, you know, because if they miss their treatment because they were stigmatized in school and, you know, they engage into a sexual relationship with another person, if you're not taking your treatment routinely, your viral load will go high and the risks of infecting the other person is higher. So because of those effects of stigma and discrimination, one other key message is, let's not stigmatize. Let us not discriminate people living with HIV. They are productive members of our society, and they can do everything that all of us can do. And if we do that, if we remove stigma, if we do not discriminate against people living with HIV, we will reduce new infections. We will then move towards achieving the goal of ending AIDS as a public health threat by 2030.
Uganda has 1,000 new infections and 500 deaths every week. The estimated total number of people living with HIV is 1.4 million.
We had relaxed when it had come down, but I think we should go back. Because now we have a chance to completely defeat it. So we should talk more.
As a leader, I pledge to support the struggle against HIV/AIDS in Uganda.
I pledge support to ending HIV/AIDS by 2030.
Join the effort to end AIDS in Uganda by 2030. As a leader, play your part in the fight against HIV. For For advice and more information, please call our toll-free line on 0800 200 600 or 0800 100 066.
This message is brought to you by the Office of the President and the Ministry of Health.
Did you know that 1,000 Ugandans get HIV every week? Did you know that every week 500 people die of AIDS in Uganda? HIV is still with us. In 2017, President Museveni launched the First Track initiative to end AIDS by 2030. We must stop HIV. The best way for young people to avoid HIV is to abstain.
Why you had to have sex at 16, at 18, at 20, and then you die, or you start having problems, which you may live with all your life? Why don't you wait, hold on, you study, finish your degree, and then you look for a partner at the right time?
Protect yourself. Abstain from sex until you're ready. For advice and more information, please call our toll-free line on 0800 200 600 or 0800 100 066.
This message is brought to you by the Office of the President and the Ministry of Health.
The estimated total number of people living with HIV is 1.4 million, and about 1.2 million are on treatment. People with HIV can still live a healthy life if they adhere to treatment.
Health is wealth. Help Uganda become prosperous by remaining healthy.
I take my ARVs every day. I am healthy and strong.
Join the effort to end AIDS in Uganda by 2030. If you are living with HIV, take ARVs daily as advised by your health worker. For advice and more information, please call our toll-free line on 0800 200 600 or 0800 100 066.
This message is brought to you by the Office of the President and the Ministry of Health.
If you are pregnant, go for antenatal care services at a health facility. Take the HIV test with your partner. If you test positive, take ARVs to protect your baby.
Because if they take those medicines, then the baby is born HIV-free.
Join the effort to end AIDS in Uganda by 2030. Take the HIV test with your partner today.
Fellow men, support your pregnant partner to go for antenatal care services.
For advice and more information, please call our toll-free line on 0800 200 600 or 0800 100 066.
This message is brought to you by the Office of the President and the Ministry of Health.
AIDS is still with us, and Uganda has 1,000 new infections and 500 deaths every week. The estimated total number of people living with HIV is 1.4 million.
We had relaxed when it had come down, but I think we should go back. Because now we have a chance to completely defeat it. So we should talk more.
As a leader, I pledge to support the struggle against HIV/AIDS in Uganda.
I pledge support to ending HIV/AIDS by 2030.
Join the effort to end AIDS in Uganda by 2030. As a leader, play your part in the fight against HIV. For advice and more information, please call our toll-free line on 0800 200 600 or 0800 100 066.
This message is brought to you by the Office of the President and the Ministry of Health.
The Candlelight Memorial Day is an internationally recognized day. It is done to remember all of those people who have died because of AIDS. People who have died because of AIDS, need to be remembered so that we stand in solidarity with the ones who are left behind, their relatives, their loved ones, their employers, because of the great work they have done. So we commemorate it every 17th day of May of each year. This year, because of the multiple events happening in the country, this had to be postponed to the 27th of May. But individual institutions, commemorate this. It can be at a workplace, it can be at family level, and you do that by lighting a candle, signify you know that we still remember you, we still love you for what you did, and it energizes us to continue with the fight against HIV and AIDS.
Let's light the candles.
And the greatest is love. And the greatest is love. Where were you when the world stopped turning on that September day? Kiss me like you'll never see my face again. Soft and tender as you came. Hold me like we'll never let. Please make
and we would like to get started. I want to draw your attention to the day's program. If you still have a cup of tea, please feel free to come with it to your table and continue to enjoy your cup of tea. We can have a working meeting. Looking at the program, we shall be starting with an opening prayer. And I want to check if Reverend Canon Professor Gideon Byamugisha is in the meeting. If not, then Dr. Enid Wamani should step in and we have our opening prayer. Once again, I welcome all those who are online and those who are watching us on the national televisions. You are warmly welcome, and it is a pleasure to be with you. Over to you, Enid. There it is.
Thank you, Chair. Good morning, ladies and gentlemen. My name is Wamani, I work for the Commission. So let's humble ourselves and pray. Father God Almighty, we thank you for this new day. We thank you for the opportunity for us to gather here and hold this national scientific meeting. We pray, Lord Jesus, that you come and guide us. We pray for wisdom in all the deliberations. We pray for those who are on their way, that they will come swiftly, and that you bless our 3 days here so that they will be constructive for our national response to HIV and AIDS. We pray trusting in your presence, and we pray that you bring all our chief guests and dignitaries in time, and let's have a fruitful time at the end of the day to meet all our objectives. We pray all this trusting in your mighty name, Jesus Christ our Lord. Amen.
Thank you very much, Mrs. Enid Wamani, for that prayer. Ladies and gentlemen, all protocol observed, we want to warmly welcome you to this conference. For those of us who have seen the program, we have a 3-in-1 event, and we are here for the next 3 days. So we want you to brace yourselves for the 3 days, and allow me to welcome you all, but to specifically welcome our conference chair and the conference vice chair. My name is Zephyr Tanzani. I work with Uganda AIDS Commission as Director, Human Resources and Administration. I will allow the co-MC to introduce herself. Gloria.
Thank you so much, Zephyr. Ladies and gentlemen, good morning. A warm welcome from the MCs and the chair, on behalf of the chairs. Please feel at home. That is what I can say. And I believe this is going to be a very productive conference. My name is Nawanyaga Gloria. I am a young person born and living with HIV. I am a human rights lawyer. I am the founder of the Y+ Music Band and the Young and Youth Apostles Foundation. Thank you.
Thank you, Gloria. So you can see that you are in very safe hands. We'll be hosting you for the next 3 days. Allow me to introduce the conference chair, Professor Paul Wako. Professor Paul Wako is a professor of pharmacology and therapeutics. He's a fellow of the Uganda National Academy of Sciences. He's also the chair of research, academia, scientists and professionals, self-coordinating entity. He's the vice chancellor of Busitema University. Please join me in welcoming him.
At the same time, allow me to introduce the co-chair of the conference, that is Dr. Dennis Tindiebwa, Executive Director, African Network for the Care of Children Affected by HIV and AIDS. Let's welcome Dr. Dennis.
The theme for our conference is HIV and COVID-19, reflecting on our vulnerabilities and resilience. So, ladies and gentlemen, we will now hand you over to the chair of the conference. Thank you.
Thank you very much. I want to draw once again your attention to the day's program. Shortly, you will be receiving the opening remarks from the conference chair. We shall have welcome remarks and recognition of delegates from Dr. Eddie Mukoyo, the chairperson, Uganda AIDS Commission. We shall have presentation of the conference objectives from Dr. Zephyr Karyabakabo, who is Director Policy, Research and Programming at the Uganda AIDS Commission. We shall have a presentation of the annual Joint AIDS Review Report from the Executive Director of Uganda AIDS Commission, Dr. Nelson Musova. We shall have an update on WICASA 2021 from Mr. Luke Amandi, who will be joining us online. And then we shall have a keynote address on global and regional perspectives on HIV and COVID-19 from Madame Anne Gisoko. I think she will also be joining us online. The Director General Health Services will be updating us on the status of COVID-19 tomorrow. We've deferred this program because he has some commitments today. But we shall simply run to the next programs after that. That is the HIV and COVID-19 among people living with HIV by Dr. Watiti. After that, we shall have an interlude, and then we shall go into the VIP session, where we shall get some statement from the United States, Her Excellency Natalie Brown, United States Ambassador to Uganda. Then we shall get remarks from the Minister for Presidents, and then we shall have the official opening by the Right Honorable Prime Minister of the Republic of Uganda. That should take us to lunchtime. And thereafter, in the afternoon, we shall go into breakout sessions. So that's how the first part of the day we will be running. And without wasting time, allow me make my remarks. I want to thank everyone for inviting me to this meeting and also supporting me as conference chair in the various capacities. In a special way, I thank Professor Dr. Tindiewa Dennis, my co-conference chair, and Dr. Kavagambe Vincent, who worked actually as the chair organizing committee. So, in salutation, allow me salute the Right Honorable Prime Minister in absentia. She will be joining us later today. The Minister for Presidents should be joining us any time from now. Her Excellency, the United States Ambassador, the Chairperson, Uganda AIDS Commission, the Director General, Uganda AIDS Commission, representatives of UNAIDS, representatives of the Ministry of Health, representatives of people living with HIV, and representatives of AIDS development partners, their chair, you are warmly welcome to this meeting. Allow me to thank all of you for putting aside time to join the rest of Ugandans on this particular event. This is the National HIV and AIDS Scientific Meeting, also featuring the 14th Annual Joint AIDS Review and the Lutaya Memorial Lecture. Our theme today is HIV and COVID-19, reflecting on our vulnerabilities and resilience. This meeting is organized by the Uganda AIDS Commission in collaboration with the Ministry of Health and the research, academia, scientists, and professional bodies as self-coordinating entities in the response to HIV. Today, researchers, policymakers, and service delivery implementers are coming together to share new knowledge on HIV/AIDS epidemic and the progress on the response. This is also the time we reflect on the implementation of the National HIV Response Strategic Plan to see how far we've been able to achieve with regards to the targets that have been set. This meeting is an important platform for dissemination of research findings, thus contributing to the evidence base for managing the HIV and AIDS pandemic. The Lutaya Day is one of the key advocacy events in this country in the national response to HIV, and we use this day also to remember those who have succumbed to AIDS, and it is also used as an opportunity to give hope to those who are affected by this problem. East and Central Africa is one of the regions that have been hit hardest by HIV. As of August 2020, 1.5 million Ugandan adults were living with HIV in Uganda. An estimated 21,000 died of HIV/AIDS-related illnesses, and 53,000 were newly infected with HIV. Much as we have had tremendous leap in changing the trend of this pandemic, we still have a lot of work to do in order to achieve the set global targets like zero new infections. The impact of COVID-19 on the HIV pandemic and people living with HIV is still evolving. And it is at such a fora that we share evidence on how the trend which things are taking. I want to give thanks to the organizers and funders and all the conference participants who have submitted papers to be presented at this conference. We are extremely grateful to the work you have done to make this day a success. I want to give special recognition to a number of funders who have made this event a success. Amongst those is PEPFAR, UNAIDS, UN Women, UNICEF, the Uganda HIV/AIDS Partnerships, and the Uganda National Academy of Sciences. I want once again to thank all of you for coming, and to the people online, thank you for putting in an effort to join us at a distance. We are extremely happy to have you at this meeting. With those few remarks, I would like to wish all of you a successful conference. Once again, welcome to this meeting. Allow me in the audience welcome the chair of the AIDS Development Partners, who is also one of the speakers. You are extremely welcome, and let's give her a big hand clap because she's been with us much more early today. Thank you for coming and thank you for keeping time. It is a pleasure to have you here. So with those remarks from the chair, allow me now invite the welcome remarks from the chair of the Uganda AIDS Commission, Dr. Ed Mukoyo. You are warmly welcome to give your remarks as the lead organization that has been at the steering wheel of having this meeting. You are warmly welcome.
Thank you very much. Thank you very much, Conference Chair. I'd like to take this opportunity first to recognize members of USC board. I would like to request them to stand up and individually introduce themselves. Use the other one.
Good morning, ladies and gentlemen who are here and those who are online. I'm Fred Barongo, Commissioner, Uganda AIDS Commission Board, representing people living with HIV and AIDS on the board.
Good morning, ladies and gentlemen. My name is Charles Emma Ofono, and I represent young people on the USC board.
Good morning, ladies and gentlemen. My name is Charles Wendo. I represent media interests on the USC board.
Good morning, ladies and gentlemen, and soldiers on the front line in the struggle. My name is William Tibiasa Mwesje. I represent the private sector on the USC board.
Good morning, everybody. My name is Dr. Lydia Mungerera, and I represent civil society on the AIDS Commission, on the Uganda AIDS Commission board.
Good morning, everybody. I'm Richard Nam. I represent the council institutions on USC board.
Good morning. My name is Nelson Msova. I'm the Director General of Uganda AIDS Commission. I'm the Secretary to the board and also a member. Thank you for coming.
Thank you. Those are the board members with whom we oversee the activities of Uganda AIDS Commission. Allow me to also recognize the following dignitaries here. AIDS development partners present, they can just wave their hands, yes. And of course, the chair of the AIDS development partners, you're most welcome. Members of self-coordinating entities present. Members of civil society present. The academia, media, people living with HIV/AIDS, ministries, departments, and agencies, and of course, those online, and the rest of you are physically with us today. I take this opportunity to welcome you all, those who are physically present, and those who are online, to this National HIV meeting featuring the Joint AIDS Review and Fidel Lutaya Memorial Lecture. I thank you for joining us to deliberate on important issues concerning the national HIV and AIDS response. Uganda AIDS Commission is mandated to disseminate information about HIV and AIDS in the national HIV and AIDS response. Therefore, by holding this scientific meeting, Uganda AIDS Commission is fulfilling one of its key areas of responsibility as prescribed by the Uganda AIDS Commission Act CAP 208. The theme of this meeting is COVID-19 and HIV, reflecting on our vulnerabilities and resilience. There couldn't have been a better choice for the theme. COVID-19 has had negative impact on the HIV and AIDS response. The deliberations at this meeting will therefore go a long way to enrich our knowledge of the effect of COVID-19 on HIV and AIDS response and how we could handle similar situations better in future. Preparation for this meeting have taken a period of more than 4 months. I would therefore like to recognize the efforts of all persons and organizations that were behind the preparations. In particular, I would like to mention the following: the Coordination Committee, the Scientific Program Committee, the Research, Academia, and Professional Associations, self-coordinating entities, and institutions that they coordinate, the National Conference Technical Working Group, the JAR Technical Working Groups, the Presidential Fast Track Initiative Technical Working Group, the board and staff of Uganda AIDS Commission. I would also like to recognize financial and material support that we have received from government and our partners, especially UNAIDS, UN Women, UNICEF, and PEPFAR. I wish you all fruitful deliberations. Thank you.
Good morning. It's now time to get a gist of the objectives of the conference, and this will be delivered by Dr. Zephyr Karyabakabo, who is the Director of Policy Research and Programming at Uganda AIDS Commission. Dr. Karyabakabo was the chair of the organizing committee. So welcome, Zephyr, to give us the objectives of this conference.
Thank you very much, Chair. IT team, I don't see the objectives. Thank you very much. What appears on this slide has already been alluded to by the chairman. This is the National HIV and AIDS Scientific Meeting, which combines the Philip Lutaya Day, which is the Philip Lutaya Memorial Lecture, as well as the Joint Annual AIDS Review. We can go to the next. This is a background which has also been given by the chair. I don't need to enter into that. But suffice to say that Uganda AIDS Commission, in collaboration with stakeholders, routinely organizes HIV and AIDS scientific meetings. For those of you who have been with us in the response, you remember in 2015, we even had regional conferences. And I'm glad that our chair today, that time was coordinating the Eastern region, which was under Bustema University. This meeting brings scientists, implementers, and other stakeholders in the response. I've already told you that this conference will feature both the Joint Annual AIDS Review and the Philip Lutaya Memorial Lecture, and the dates have been given, and we know very well that is hybrid. Most of us will be virtual there, out there, while a few of us are here. Continue. Our objectives are mainly three, and they are related to the three important areas that we are covering. And the first is to discuss research and practices in basic biomedical, clinical science, epidemiological, behavioral, socio-economic, legal, human rights, and cultural issues in the context of the HIV and AIDS response. And that is to do with the HIV and AIDS scientific meeting. The second is to review the performance of implementation of the first year of the HIV and AIDS response, and that is the JAR. And the third concerns the Lutaya Memorial Lecture, and we are commemorating the Lutaya Day. The program highlights for our three-day meeting, we shall have keynote speakers. Some are national, some are international, as the chair has already alluded to that. We have invited papers to be presented in plenary on each day. The program is very clear for those of you who have copies. We have sent copies of the program to everybody. We have abstract-driven papers which will be presented in parallel sessions, and we have 3 parallel sessions. Today afternoon, we have parallel sessions along the 4 tracks. Tomorrow, after break, and tomorrow afternoon. And by tomorrow afternoon, we'll be almost done with the area of science. And then the third day is mainly a community day and the closing ceremony. We also have abstract-driven posters which will be presented online. Our IT team will be demonstrating later how you can go to our virtual space and you are able to navigate through the posters there, as well as the exhibitions. So we have exhibitions. Some are physical, outside in the grass. You will pass there and see those who are exhibiting. And then we have exhibitions which are online, and our IT team will take us through. And we also want to mention that with support from UNFPA, yesterday we had a pre-conference meeting which was a satellite session, and it was on the National HIV Prevention Roadmap. These are the tracks which are going to guide our discussions, mainly under science. The first track, there are 4. I will just run through the tracks. One is epidemiology and HIV prevention. The second, and it has 3 sub-tracks. That means we shall deal with the first one today afternoon, the second one tomorrow after break, and the third one tomorrow after lunch of those sub-tracks. And that applies to all the tracks and sub-tracks. Track 2 is basic science, care and treatment. Track 3 is social support, human rights and gender. And the last is system strengthening and strategic information. What are the expected outputs? At the end of this conference, for sure we shall have an aid memo detailing the meeting deliberations, the recommendations, undertakings for the next year of implementation of the National HIV and AIDS Strategic Plan, as well as recommendations for the science part. And we shall also have a conference report where we shall cover mainly the science that will be discussed during this conference. Yeah, that's the end. Thank you, ladies and gentlemen. These are the objectives of the conference.
Thank you very much, Dr. Zephyr, for guiding us through the objectives. And now we would like to invite the Director General of the Uganda AIDS Commission, Dr. Nelson Musoba, to take us through the annual Joint AIDS Review Report for the year 2020-21. You are welcome, Dr. Musoba.
Thank you very much. The conference chair, Professor Paul Wako, and the co-chair, Dr. Dennis Tindiewa, the chair of the AIDS Development Partners Group, the acting UNAIDS country director, representatives of AIDS Development Partners, the chairman of Uganda AIDS Commission, and the commissioners present, all of you, ladies and gentlemen, all protocol observed. I'm going to use the next few minutes to share highlights of the review of performance for the last year, which was the first year of the current strategic period and our current national HIV strategic plan running from 2020-2021 to 2024-25. And if we can go to the next slide. I will, as you can imagine, the report, we've not circulated hard copies of the report, but it has been shared with all of you via email, at least all those who registered for the conference. We have your emails, and the team should circulate that to you. It has also been uploaded on the Uganda AIDS Commission website. We shall avail a few hard copies for our archives later, but we have had PowerPoint copies to help us navigate through, and that is the outline of my presentation. In the next slide, as we know, in the current strategic period, we upped, first of all, Uganda achieved its 90-90-90 targets by 2020. That's one of the results we shared previously. And following that, while we were preparing the new strategic plan, the new targets we set for the next 5-year period is 95-95-95, meaning that 95% of people who have HIV test and know their HIV status, and 95% of those who test positive are enrolled on antiretroviral therapy so that they are able to treat the virus, and 95% of those enrolled adhere to their treatment to achieve viral suppression. Now you can see that out of the 95-95-95, we are already achieving the first 90. And we had a lot of engagement with the team, as you know, how we have managed to do this. And I will speak shortly about some of the factors that have enabled us as a country to achieve the first 90. Of course, there are gaps. That is the average. But when you go into the subgroups of the populations, if you look at the young people, if you look at the key populations, not all the population subgroups have achieved the first 90, 95 rather. But when you take the average, that is what has been found. On the second 95, we are at 90, not yet there, but this being the first year, I think we have some work to do for the next 3 years so that by 2025, we'll see where we are. On the viral load suppression, which is the third 90, we are at 86%. So a lot of more work to be done for the third 90. conference chair will just pause a little. We are receiving Her Excellency, the U.S. Ambassador, Ambassador Natalie Brown. You're most welcome. Okay, we can sit. We can sit. Thank you very much. I was just beginning the presentation of the annual joint review report, and I was actually on the first slide of 95, where we are in terms of achievement, and I just explained that we already, by average, seem to be hitting the first 90, but we are not yet there for the second and the third. And there is a lot more work, and when you read the detailed report, you will see that, by the subpopulation groups, the children, the adolescent girls and young women, the key populations, the challenges are much bigger than what the average. So averages sometimes do not tell the full picture, and there are things that may not be seen when you're looking at the average. But let me just speak a little. Why do we seem to be ahead and for instance, achieving the first 90? And I would like to applaud, our partners, the people we work with. First of all, through the efforts of targeted HIV testing to find the HIV-infected persons, using index partners to find index affected partner notification, index tracing, so that when the first person tests positive, they follow up those who may be connected to you, whether it's the children or their sexual partners. That is partly responsible for the yield. There has also been a scale-up, of the high-yield approaches. There has been optimization of the ARV regimens, and generally improved program reporting are some of the efforts that are behind the results that we are seeing. In the next slide, we look generally at an overall picture of where we are. So look at the HIV prevalence among 15 to 49. You know that from the Ministry of Health UFIA results of 2016, the prevalence is 6.2%. But modeling our programmatic data, it's showing us that prevalence is down to 5.4%. This is good news, very good news indeed. Although we know, of course, there's an ongoing study by the Ministry of Health. COVID has delayed those results. We do not have them yet. We do not think they will vary very much because previously we've done the modeling of our data, and very often the results of programmatic data are not very far from what we see from the population-based survey. So I can invite you to already celebrate these results of 5.4% HIV prevalence amongst the adult population. The estimated number of people living with HIV, we still at 1.4 million. We have, we observed 38,000 new infections amongst adults, 5,300 of which were among children. Very, very high number, unacceptably, given the technologies that are available to us. The AIDS-related deaths are down to 22,000. Market reduction, but still unacceptably high. You wouldn't want to lose anybody in relation to AIDS. And we have still an approximate 900,000 orphans. But before I go to the next slide, like I told you, if you go in the other population groups, for instance, the female sex workers, the prevalence rate is as high as 31% when that data is disaggregated. When you look at the partners of female sex workers, prevalence is 18%. Uniformed services, prevalence is 18%. Men having sex with men, prevalence is 12.7%. So very, very high prevalence. So we can celebrate the 5.4, but we still, have those population subgroups where we have some work to do. Next slide now focuses on the prevention, looks at key achievements within the prevention subcomponent. Next slide, please. And here, we were able to develop, again, USC coordinating different partners, a number of policy documents and plans in place. We finalized the national research agenda, and the detail will be shared in one of the plenary sessions during the 3 days conference. We also developed the national HIV communication strategy. Communication is quite key because in our review, we found that access to information is still a problem, and misconceptions still exist, and probably that is what is driving HIV stigma and discrimination, because if you don't have an accurate and full understanding of how HIV is transmitted and how you can prevent it, then there are bound to be misconceptions, and therefore we think that is an important milestone for us to have accomplished. The National Comprehensive Condom Programming Strategy and Implementation Plan was also developed. We recently launched the Anti-Stigma and Discrimination Policy. We launched the guidelines for harm reduction and drop-in center operations. We were also able to have the first medically assisted treatment center established. This is for people who inject drugs and drug use, and this is in Butabika. That is also a growing population subgroup that we have to continuously look out for, and we think that area will help. We had close to 500,000 male circumcisions, slightly lower than the accomplishment in the previous year, only 8% of the target within the age group that had been targeted. In our next slide, we are looking at that subpopulation group of adolescent girls and young women, a very large group. We have a strategy in place, and we had comprehensive prevention services reaching out to approximately 400,000 AGYWs in the high burden districts, you know, and the package and range of them. The color codes can show you the different partners and the regions which they are supporting. When you look at, for those, if you're able to see the colors, I know if you're at the back of the room, it may not be very clear, but we name some of our partners in this. You know, the deep blue districts are PEPFAR. We have Global Fund with especially the SBCC intervention. We have the districts that have both UNFPA and PEPFAR. We have those that have Global Fund and PEPFAR. We have the districts, the Karamoja and Eastern region with UN Women supporting that. And then what we've called the non-DREAM districts, and then the Global Fund Comprehensive Districts. So we have a few parts of the country that are not yet receiving the comprehensive package for the adolescent girls and young women. And yet, in our investment case, when we had mapped, we saw that this is one subgroup which, when you apply interventions, you get a maximum reduction in new HIV infections. But the cost remains one of the prohibitive, you know, aspects for us to apply interventions to AGYWs to scale and you know, giving them the full packages. Next slide, please. Here we are looking at HIV testing specifically. We managed to reach more than 6 million people tested, and 89% of those were linked to antiretroviral therapy. And also, the Ministry of Health is able to do what is known as recense testing, which showed that 13% of those who tested positive had acquired the infection. Their infections were less than 6 months old. So it meant that we can go back, we will speak with the experts and working with UNAIDS to see how many of these can be directly attributed to the COVID effects, for instance, because we know that there are a number of factors during the COVID time that were specifically played a role and were you know, predisposing factors. But you can see in the recent testing that the number of females is particularly higher. If you look at that table for the different age groups, of course, the increase is highest in age group 20 to 29. The previous, for male compared to the female, and specifically for the period April to June. So again, that helps us target our interventions. If we know the most affected age groups, we can further look at this data and see which population groups this is coming from. Next slide, please. this is specifically looking at prevention of mother to child. Overall, there was a decline in the access to HIV testing services and maternal ART. You can see retention specifically, being a problem area that at 12 months after ART start, we had only retained 81% of the mothers. So where are the rest of these mothers going? Have they just moved from the place where they are accessing services, or is it that they have totally dropped out of our service? And if they have dropped out, that would be of major concern. What is the reason? Is it stigma? Are they failing to find support to move to the health facility to access the service? That is one area we need to have joint effort. We need to work with all sectors of our population, with the faith leaders, with the cultural leaders, with the political leaders, because it's a community mobilization effort, Chair, to get this. Once the mothers know that if they go to the facilities, they want to be treated well, they will not access services quickly, that can be a factor. If in the homes, they know that their HIV status will be used against them, that will be a factor for them not to seek testing. So where is the 19%? And why is it not being retained is a major question that we can deliberate. You can see that early infant diagnosis within 2 months at 74%. So again, that is a question we can debate and say, what is the problem here? The little ones do not speak for themselves, and somebody needs to be there to look for them. So is the mother not seeking services and dropping out with a baby? But we know traditionally that the African woman will reserve the last bit of whatever is left for the child, even when the mother is going hungry. So is it possible that even when mothers are dropping out, they could have their babies access the services, or in this case of health services, that is not possible? And overall maternal viral load coverage is at 61%, which is also unacceptably low. Next slide, please. In the area of pre-exposure prophylaxis, there was a scale-up. So here is a result to celebrate, probably not where we should be, but we had over 85,000 newly enrolled individuals on PrEP, but coverage remains low amongst key and priority populations, and 80% of those who are eligible, were started on PrEP. And PrEP, the pre-exposure prophylaxis, is largely for populations who are at high risk of, acquiring new HIV infections. That includes the key and priority population groups, the discordant couples, somebody probably having multiple sexual partners, concurrent, and at high risk are parts of our population whom we start on PrEP. And we seem to have done well to have scaled up to close to 300 sites and tripled the numbers that we had before. Next slide. Next slide, please. Okay, so you've jumped a slide on comprehensive key population programming. Can you move one slide back? Okay, the person working the slides for me seems to be having challenges, but we recognized in the review that we've had policy guidance in place for comprehensive key population programming. There has been capacity building. There have been an increase in drop-in centers. We've standardized data collection tools for these groups, and the services have become more comprehensive. I already spoke about the first medically assisted therapy center established in Butabika to support these population subgroups. And we've had 275 enrolled at this center up to date. So that is what we've been able to do within that population subgroup. Thank you. In the next slide, we are talking about social behavior change communication. Again, a key component. I had spoken earlier about our having recognized that a significant section of our subpopulations still do not have the full and accurate information, hence leading to stigma discrimination, and also persistent myths that predispose them to HIV infection. But we've been working with other actors. In this slide, you see a picture of the Katikkiro of Buganda, whom we've been engaging cultural institutions, and they are very influential. They reach large populations. We've also engaged faith-based populations to be able to get the message around infections. I mean, HIV, the risks, risk perception, and that way, a message that we may not be able to get across as public health professionals and experts will easily get across if we are using a third party as a medium for carrying these messages. And this is an example at a ceremony where, USC signed an MOU with the Kingdom of Uganda, and we, sharing very specific data. What you see in the background is a prevalence map for the Uganda region. So we show them that within your region, this is how the mapping of HIV is. This is what is happening within the districts. And regionalizing the epidemic seems to work because we saw a lot of interest from this stakeholder group. Under care and treatment, our antiretroviral coverage stands at 92%, but when you break it further, it is the females overall is greater than 95%. So as always, in that subcategory, we know that even in terms of the first 90, they have been performing better than the males, and the second and third 90 is also better. The viral load suppression has improved due to optimized regimens, but it still remains low. The data numbers are mixing up because there is where the teams were computing and using population subgroups. So if you break the age groups and you are using the denominator either as the adult population or children or key populations, you'll find the coverages change slightly as compared to when the denominator is the overall population at risk. This slide is looking at retention. 12-month retention, and generally we need to do more work here because we noticed that the overall retention, the NSP target was 95%, but the overall was 71.5%, but much lower amongst key and priority populations, below 30%. And when you look through the different subcategories of those populations, then it is the coverages under within the red is showing us that we've got a lot of work to do there to be able to have this group access services, adhere once they have accessed, and be able to come back, and we should be able also to capture data. You can see that we don't have baselines for a number of them, also a challenge around capturing data with those subgroups. In the area of HIV, TB integration, we've had an improvement in the TB preventive therapy coverage and completion rates. For instance, when you look at that data, in HIV care settings, up to 90% of people for HIV were screened for TB, and 1% of those were found to have TB, and 85% of those were enrolled on treatment. In TB care settings, up to 8% were screened for HIV, and 34% were found positive, and 97% were enrolled on ART. So our colleagues within the healthcare settings are doing a great job. I think the Minister of Health, we need to commend them for that, because you can see the numbers there are really good. What is happening after that is where we need now to put our efforts, that when we screen these people, we identify them and release them. Either not sufficient information has been given, or the amount of counseling, or the follow-up and support, we seem to be losing them along the way. And that is where the efforts and investments need to be. In the area of social support and protection, stigma is again an area we've consistently identified as a bottleneck, and like I spoke earlier, We launched the National Policy Guideline on Stigma. We are in the process of rolling it out to all the key stakeholders at the local governments, not just disseminating, but explaining the content. We did the national rollout, and would like to go to all local governments, explain the content, and guide them on how they can deal with the issue of stigma. And we think that this will be one of the areas, if we do well, that we will make roadway. The media campaign has been conducted, and we've been trying to work with media as much as possible. There was a dialogue that was done. We've engaged leaders, and we've had AIDS competence trainings for health workers. That's a picture of the Permanent Secretary of the Ministry of Health at one of the events trying to speak about stigma. The other structural driver or barrier is the area of economic and psychosocial support. And that slide, highlights and benchmarks examples of what was done. I don't think this is all, because there are lots of other interventions that are done elsewhere. I see our hero and champion, Major Rubaramira, in the audience. I know that Operation Wealth Creation is doing a lot of work in supporting households, in ensuring that household incomes are improved, but we are not necessarily able to capture this data and link it to how much that has done, to reduce vulnerability. So, although this slide has examples and shows some of the efforts, especially done at the central level through the Ministry of Gender, through our PEPFAR initiatives, the Global Fund, and the Ministry of Health, I can call it a sample list, and no way exhaustive in what all the efforts that were done out there. Gender-based violence is an area that a number of interventions were done. We know that gender-based violence impacts the risk of and increases vulnerability greatly to the risk of acquiring HIV, because it makes those affected unable to prevent HIV, unable to seek services, including information. But we see that, unfortunately for us, you can see from that first bullet that GBV increased by 44% between the previous and the year under review. We partly know that this could be linked also to the effects of managing the pandemic, because when the resources are low, when you're struggling, you're looking for where does the power lie, how do we make decisions on what to prioritize and what not to prioritize, and lots of things happened in there. And according to the information that was gathered so far, more females were affected compared to males. There was an attempt to link of linkage of services, including legal, clinical, and referring, but clearly under lockdown, there is no way this was going to be done smoothly, and reporting wasn't harmonized. So we need to pick up from where we were to be able to take this forward. In the area of legal and policy framework for people living with HIV, key populations and vulnerable groups, we've had I've shared a bit of what has been done, put in place in terms of guidelines, stigma reduction, school reentry programs. The Ministry of Education has done a bit of that, and there has been engagement of some duty bearers and capacity building for some of the groups. Chair and co-chair, moving towards the close. Under system strengthening, we had a number of guidelines developed and also disseminated. I'll not go into every single one of them, because for guidelines, we will start to see results. One, if we disseminate, but also two, once we operationalize and we start to implement what is spelled out in there. So having guidelines in place is not a celebration in itself. But the one that I would like to single out is in terms of financing which is point number 4 under the Presidential Fast Track Initiative, is the HIV/AIDS mainstreaming. You know, we've worked on this together over the last 3 years, and we are seeing lots of progress in terms of stakeholders. We've done a number of things, and one of the single results I can mention, which is not necessarily in this slide, is that we are finalizing an analysis of the government ministries, departments, and agencies in terms of those that have planned and budgeted for 0.1 funding and integrated that in their plans and guidelines. And 83% in the financial year under review were able to do that, compared to 34% 3 years back when we started. So we are making progress. The next step will be for us to check and see whether these finances are actually being spent on the HIV and AIDS activities, and then we can follow that up to see the impact that this is having. This slide shows funding contribution by source and resource tracking, and chair and co-chair and members. What is also not here is that working with the partners, we are in the final stages of developing the AIDS Development Partners Directory. It shows where each of the partners is, what they are contributing, and the services for coverage. So this will be a good triangulation on the National AIDS Spending Assessment and the other reviews, and will give us a good picture and help us rationalize, how we should share and distribute the resources that are available. As I move towards the conclusion, Chair, I'm going to speak about what the impact of COVID-19 has been on HIV. This is a loaded slide. It has, it is showing us HIV testing. I spoke about HIV testing. It is also showing those who are able to get enrolled on ARTs, and it shows also the antenatal visits. So we saw a reduction in HIV testing services by 41%. We saw a reduction on ART enrollment by 31% compared to the targets. SMC, we also saw a reduction by 40%. I talked about antenatal. TB new cases, we also saw a reduction. And there is also a COVID-attributed mortality. There is information to, from what we're analyzing, that there is what can be attributed directly to COVID. But we've also seen a rise in unemployment. From other data from UBOS, the rise attributed to poverty, the child labor, domestic violence, I've spoken about GBV, defilement. We've seen, reports around adolescents, adolescent pregnancies, and vulnerability generally to HIV, because we know what that comes with. So the impact of COVID certainly has been huge, and we know that a number of mitigation measures were put in place by government, by our partners, the food distribution, the cash transfers, currently the vaccination efforts and the drive, and appreciation again goes to our partners and the Ministry of Health. Of course, we also saw the global inequalities in terms of access to vaccines. We know that as the developing world, we had to stay behind, and I think we are still staying behind in the queue, even as we wait for access to the vaccines. But I think we have a number of vaccines that are in the country, and ensuring that the population goes out and accesses this is what our efforts should be. This is my last slide, Chair, and it's looking at what are the key issues and way forward. I've just talked about the COVID-19 impact and how it increased vulnerability and disrupted services. We've seen that children and adolescents are lagging behind, and we need to put efforts in those subgroups. We've seen suboptimal coverage of prevention services. Structural barriers continue to persist, stigma, GBV, and some of the laws. Retention in care, I've already highlighted that as a problem, and capacity gaps, both amongst the CSOs and government entities, including the issue of coordination. Missing data, we've already spoken about that. And on one side of our slide are the things that we need to do. We need to have a renewed focus on children and adolescents. We need to address the structural barriers. We need to enhance the differentiated approach. And I want to applaud the civil society colleagues at this point, because in the early part, the first wave and the first lockdown, we relied on those networks to swing in action and link us to the households and enabled, continuity in terms of ARV services. We await to see the UFIA results. We had invited the Ministry of Health to come and share the current UFIA results. They told us that they are not yet ready. We would like to see where we are currently, so that our next interventions are designed and benchmarked on this. We also need to work on the reporting systems to harmonize them for GBV and for adolescent girls and young women. Chair, I'd like to appreciate you. I'd like to appreciate the audience. I appreciate the partners and all the stakeholders who have been with us in the fight against HIV and AIDS. I thank you for listening.
Thank you very much, Director General, Uganda AIDS Commission. There is hardly any time for discussion in this session, but in case you need any further clarification, I think feel free to engage the Uganda AIDS Commission. Allow me also in a special way welcome Your Excellency, the American Ambassador to Uganda. We are always grateful to your government for their consistent support in our efforts to fight HIV/AIDS. Thank you very much, and you are warmly welcome. My co-chair will now invite the next presenter.
Thank you, Chair. Before I invite the next presenter, I also want to thank the Director General, Uganda AIDS Commission, for an excellent, detailed presentation. This was really very rich, and I'm sure that there will be a lot of discussions in the breakout sessions, let alone where a lot of interactions can take place, so that people can learn a little more and can focus a little more on your presentation on the key issues and way forward. And I'm sure Her Excellency, the Ambassador Natalie Brown, will take these messages back to the PEPFAR to focus in a special way on children and adolescents, because they are lagging behind in all the indicators. Welcome, Your Excellency. The next presentation is online. As you are aware, ICASA is taking place next month in Durban, South Africa, and online we have the director of ICASA, our friend, Mr. Luke Ahmad Boder. As you know, Luke is a key friend, and we should have had ICASA in Uganda this next month, and we are still looking forward to hosting ICASA next. So Luke, if you are listening in, you are most welcome. I am here with a group of participants, both virtually and physically present, and they are eager to get an update from you on next month's ICASA in Durban. Luke, you are most welcome. Please go ahead.
Thank you, Mr. Chair. It's always a pleasure to be in Uganda, virtually or in person. I will take the opportunity to also greet all my people from Uganda, all the people from Uganda, and with all due protocol observed, I will express the salutation of my board, the Board of Society for AIDS in Africa, and the whole State Committee meeting of ICASA 2021. Saying that, I would like just to go through, because I have 10 minutes, to go to few slides to give you just the update of ICASA 2021. As you know, ICASA 2021 is always based on 5 principles that we call the SSF, which is a strong structure framework of ICASA. And this strong framework has 5 principles, which is strong governance system, public and private partnership, institutional memory, innovation, adaptability, and flexibility, and crisis management. These are the 5 principles that really help us to organize ICASA over the years. And it will be good that we share with you, because often people doesn't know the principles that guide ICASA, and ICASA has been successful for so many years, and that platform is a vibrant platform for the whole continent. Saying that, for this ICASA 2021, so far, as you have noticed, the program is online. We have 15 plenary, and you can see that we have some key personality at the plenary program, like Ambassador Gosby, just to mention him. You can go to our website, you will see most of the plenary. We have one of the best plenary so far, 15 of them. All of them are pledging to come. We have 78 abstract oral presentation, and all the oral abstract presenters are ready to come. We have 11 non-abstract driving sessions. We have 18 special sessions. We have 4 workshops, one of the best. You can check on the program, especially for people population workshop. We have 4 pre-conferences. The only put here, we have pre-conference on people on MSM. We have pre-conference on youth. We have pre-conference on accountability international, and we also have a pre-conference on biomedical. We have so far 69 satellite sessions, and this time around we could not have a community village as usual, because of the pandemic, because of COVID-19 pandemic. Then we changed the system into what we call the community program session. And so far we are having 24 community program sessions. The program session, we have 8 networking zones within the program. All the community are part of that networking zone, because we have networking zone of disability, networking zone of people living with HIV, networking zone of sex workers. We have 8 of them, and we put them at a session, and we have a community room session for them, because we could not host ICASA community program as we used to host because of ICASA, because of the pandemic, of COVID-19 pandemic. We cannot, based on that, we hope that the community will understand, and maybe in 2023, we have 3,000 square meters for the community village as we used to do usually. We hope so, because COVID is still a problem in our continent, and we need to take note of that and make sure that all our delegates are safe. Saying that, we have over 300 abstracts, and all the abstract poster is 379. They are all virtual this time around. Because of COVID-19, we put them virtual. As you know, ICASA 2029 is an hybrid meeting, and we have both virtual and in-person attendance. And so far, we have a total of 479 speakers confirmed, both virtual and in-person. Let me also give you some statistics. You can see that from now, we have the 10 best countries that are coming for ICASA. They are from South Africa, Kenya. Uganda is in the 4th position, you can see. And that you have the statistics for the 10 best countries, both for registration, for virtual. We also have South Africa on the lead. After that, we have Nigeria, and always Uganda, on the 3rd position. And you can see that so far, as a registered delegate, we are planning, because this conference will be an hybrid conference, we are planning to have a minimum of 750 in person, and at least 4,000 virtual. As today date, we have, as a paid delegate, we have 344 paid delegates. You can see the statistic here is 60%, and as virtual, we have 233 paid delegates. However, we give this year 1,260 virtual scholarship. Now you can see that at today's date, we have more than 2,000 registered so far. And you can see that in terms of visitation of our website, you can see that we have the 10 best countries that are visiting ICASA website so far. You will see we have United States, we have South Africa, we have Nigeria, Kenya, Uganda, Zimbabwe, France, United Kingdom, and Ghana, including the Netherlands. These are the glimpse of the best country that are visiting ICASA. Don't forget that we have 150 countries that are visiting ICASA on daily basis. But we are sharing with you the best 10. Saying that ICASA, we are now in Uganda, in Africa. I'm in the team. You know, we are finalizing the logistics for ICASA 2021. And even though we are not in Uganda, I think that we are expecting Uganda here. You know, we are expecting Uganda here because the board has decided to give a free booth for Uganda. And I need to express this to you that you are welcome, you are invited. The Board of Society for East Africa agreed free booth for Uganda. And also let me also inform you that for this year, it seems that we have one of our member, the prominent member from Uganda that is now an upcoming board member of Society for AIDS in Africa. This is what I want to say, to share the progress report of ICASA 2021. And also let me make one comment. Thank you for Dr. Nelson to invite us, you know, and also it's not easy to present a progress report, especially when you have a mask, you know. This is the new normal. Thank you, Dr. Nelson. I would like that going forward, we should call all the leadership. One, they are proposing communication in terms of COVID-19, they should couple it with HIV prevention. It will help a lot our community, and it will help a lot our continent, because we have a lot of strategy in terms of COVID-19, but so far we are not seeing any communication on HIV. It's better that it will be very appropriate that we should appeal to all the stakeholders so that when they are publishing a communication on COVID-19, it should be coupled with HIV communication in terms of prevention. Thank you so much for your time. We really appreciate to be with you, and we hope that we welcome you soon in South Africa. Thank you. Mr. Chair, you have the floor.
Thank you very much for that update on ICASA. And now we would like to proceed to the keynote address for this meeting. I take this opportunity to invite Anne Githuku Shongwe, Director for East and South Africa in UNAIDS, to give her keynote address. She's online, and so I think she should be able to join us shortly. Thank you.
Anne, are you there? Anne, are you there? Probably she's there? Okay. Please go ahead, Anne, if you can hear us.
Yes, I can. I was trying to open my video, but I was not able to. Good morning.
Good morning. We can see you now.
You can see me now. Thank you so much, and good morning to you, sir. Thank you so much for this invitation. I also want to recognize the entire leadership of the National HIV and AIDS Scientific Meeting of Uganda, the Permanent Secretary, and all the leadership from Uganda. I just want to recognize you right now. I'm going to start sharing my screen if that's okay for you. So give me a second. It's not allowing me. There we are. Good morning and apologies. I was actually opening a separate meeting in East and Southern Africa as well. So I am really my apologies for the delay. But I want to start out by congratulating Uganda for sustaining what has been a very important conference that the world has looked to every single period for many years to be able to actually drive and gather the data and information that is required to drive the work on HIV and AIDS. On this issue of vulnerability and resilience, I want to start out by giving you an overview of the status of HIV and the most recent data that we have as UNAIDS on the status of HIV, the magnitude dynamics of the HIV pandemic. I know that most of you are familiar with this, but really just to have a picture that we're continuing as our region. We host 55% of the 38 million people living with HIV. We are also the host of 44% of new HIV infections that are 1.5 million in this year. New AIDS deaths also have continued at 46% in our East and Southern Africa region. And so while we are making some significant progress in the response to HIV and AIDS, we are also seeing some areas where we are lagging. Testing and treatment is an area that we have made particular progress, and we want to congratulate Uganda for being very close to the 90-90-90 targets. You have surpassed the know your status, and the viral suppression is coming soon, and we look forward to you achieving the 95-95-95 testing and treatment targets for 2025. So congratulations to you, Uganda. So as I look at the status, really just to say that our region has made the strongest progress against the HIV epidemic since 2010, with declining HIV infections on the one hand, amongst, overall, but particularly amongst children, the sharpest reductions in any region. But we are also the region that is highest affected. What for us is very disturbing is an estimated 58% of new infections that are coming particularly from adolescent girls and young women. We have more that are coming from sexual populations and their sexual partners, who accounted for 32% of new infections in 2020. The good news is that unlike in the past, when we were looking at this epidemic, we now know who is getting infected, who is infecting who, we know where they are, and we are able to target our solutions. Overall, there are 50% fewer deaths due to AIDS-related causes in 2020 compared with a decade earlier. And testing and treatment coverage for men continues to be significantly lower than for women. So as we have this discussion from an inequalities lens and from a disparities lens, the more information we have about who it is that we need to target, the more chance we have of being able to provide better and more focused solutions. So in this instance, to achieve our 95 targets by 2025, it is critical that we invest in men in particular, and that we also invest in children and cascading to make sure that testing and treatment is focused on them as well. Efforts to improve sexual and reproductive health and rights, including the expansion of comprehensive sexuality education and programs to reduce gender-based violence, gender inequality, harmful practice, and child marriage that perpetuate the violence and the infections that we see amongst girls, are gathering pace in many countries and is of great concern to us. Stigma, discrimination, and human rights. In general, the region still experiences high rates of stigma, discrimination, and human rights, and we are conducting stigma indices across the region to make sure that we understand what is happening, and we include sexual and gender-based violence amongst these concerns. Key populations in most of our East and Southern African countries can't associate and access services freely in some areas. There's continued shrinking space, but on the other hand, we have other key populations whose access has significantly improved. So again, we see some disparities here where some populations are able to access, some are not, and we need to be able to make sure that it's available for everybody. There is high unmet family planning needs, but in particular, we have seen a surge of what we normally call teenage pregnancy, which I would like to change and term the perpetration and violation of young girls that is resulting in unwanted and unplanned pregnancies of girls of very, very young ages. This has become epidemic proportions in our region during COVID, during lockdown. It has been a real shame for us in East and Southern Africa to be able to see that as young girls are locked up in their homes with family members, that there were violations in countries here. I'm sitting in Kenya right now, and there are in 2 counties, 4,000 young girls reported pregnant. We are also seeing about 60% of the transmission of new cases of teenage pregnancy in this country, of new AIDS, HIV cases amongst children, coming from teenage pregnant girls. And so we need to treat this very specifically and call it what it is, because it is a perpetration, and in many instances, it is unwanted, and it is from intimate partners who violate young girls. COVID has worsened the situation, and really we have seen the result of that. The financing landscape for the HIV response, the distribution for the last few years, if you look at that, a large proportion of our investment has been focused on our commodities and treatment agenda. In yellow, this is what you see. If you look at East and Southern Africa, by 2025, over 50% of our resources are investing and have been investing in the commodities agenda, the antiretroviral treatment agenda. But according to our global strategy, and we will talk a little bit more about that, the prevention agenda is a growing one. So this paints a picture for you, but it also paints a picture of the direction that we should be taking and how much more we should be investing in the areas that need our greatest attention as we drive to end inequalities, to end AIDS. I know this is not very clear for you, but it just gives you a picture of what the trend has been in terms of resource availability in our region. So to the top left is East and Southern Africa, where you see the resources coming from our domestic resources, which has grew in 2016. It's had a bit of a dip, but we're seeing a rise in 2020. And we really are looking forward to increasing domestic resourcing across our region In some regions, and we've seen, for instance, in the SADC region, there is now so that we have stronger domestic investments in our AIDS agenda. This is giving us a picture of the COVID situation, and we must recognize that this is an important one, that we are still far from out of the woods, that though we have initiated the vaccination drive, we are still very, very far. And in Uganda, the figure there is 5.1% of those who are fully vaccinated. So we are a journey away before we can reach a place where we know for sure that we have a critical mass that will keep us safe and keep us to preventing from COVID-19. So where are we going? As we imagine this future of ending inequalities to end AIDS, we have come up with these indicators that will help us to understand what are the targets that we need by 2025 to reduce inequalities, to end AIDS by 2030 as well. So our 2025 targets to reduce inequalities and reduce AIDS, 10%, less than 10% of people living with HIV and key populations experience stigma and discrimination. Less than 10% of people living with HIV, particularly women and girls and key populations that experience gender-based inequalities and gender-based violence, are less than 10%. That less than 10% of our countries have punitive laws and policies. Discriminatory laws must be ended in our countries, in line with our global, regional, and national commitments. 95% of people at risk of HIV use combination prevention. The 95% agenda of HIV testing, treatment, and viral suppression amongst adults and children continues. 95% of women access sexual and reproductive health services. 95% coverage of services for eliminating vertical transmission. And these are linked because we saw, as I said earlier, that many of these vertical transmissions are happening from young girls who are not necessarily accessing sexual and reproductive health services. 90% of people living with HIV receive preventative treatment for TB as well. 90% of people living with HIV and people at risk are linked to other integrated health services. So in the context of universal health coverage. Let me share with you now our strategic priorities that are going to enable us to achieve those targets. We have 3 strategic priorities, and I know many of you were involved and engaged in this, but I think it's important for us to take a look at what is going to be leading our agenda for the next 5 years. Remember the Ending Inequalities agenda to end AIDS. So the strategic priority 1 is to maximize equitable and equal access to HIV services and prevention. So primary prevention continues to be important for the key populations, adolescents, and other priority populations, including adolescents and young women and men in locations with high HIV incidence. This is what we want to achieve. Adolescents, youth, and adults living with HIV, especially key populations and other priority populations, know their status and are immediately offered and retained in quality integrated HIV treatment and care that optimizes health and well-being. The tailored, integrated, and differentiated vertical transmission and pediatric service delivery for women and children, particularly adolescent girls and young women in locations with high HIV incidence. I want to point to one thing in this strategic priority area. We are now increasingly across countries, and I trust that Uganda is the same, has granular data that is telling us what is happening district by district, not just on HIV, but on this in other important data. What is happening with adolescent girls and young women in relation to this teenage pregnancy information that we're finding? What's happening in terms of violence, sexual and gender-based violence? What about the stigma and discrimination? What about the services, the more that we are localizing our responses to understand the disparities, because what we have seen is even where we have achieved our 90-90-90 targets, that we have achieved them overall on average, but we need to focus on those districts that have, and populations that have specific challenges that we need to use to be able to up those numbers. And so the issue of inequalities and disparities is very important in maximizing equitable and equal access to HIV services and solutions. Strategic priority number 2 is about breaking down barriers to achieve HIV outcomes. Fully recognizing empowered, resourced, and integrated community-led HIV responses to transform and sustain HIV response. The more that we are able to work with our community health workers, work with communities in general, bring in our traditional church leaders and other community leaders to be able to support this, especially in those last mile, hard to reach, left behind communities, the more successful that we would be. That people living with HIV, their key populations and people at risk of HIV, enjoy the full human rights, equality, and dignity, free of stigma and discrimination. That women and girls, men and boys in all their diversity, practice and promote gender equitable social norms and gender equality. And they work together to end gender-based violence and mitigate the risk and impact of HIV. That young people are fully empowered and resourced to set new directions for the HIV response and unlock the progress needed to end inequalities and end AIDS. In strategic priority 3, we go back to that discussion I started there earlier about fully resourcing and sustaining efficient HIV responses and integrating into systems for health, social protection, humanitarian settings, and pandemic responses. So we're fully funded and efficient HIV responses are implemented to achieve the 2025 targets. For those countries that do not yet have, and for Uganda, transitional strategies that can start driving for more and more to domestic investment is very important for a fully funded and efficient HIV response. Health systems for health and social protection schemes that support wellness, support livelihood, and to reduce inequalities and allow them to live and thrive is very important for this global strategy. And the result, Area 10, is fully prepared and resilient HIV responses that protect people living with HIV at risk in humanitarian settings and from the adverse impact of current and future pandemics as we saw with COVID-19 and other shocks. So in summary, the priority actions for ending AIDS in our region are for us to expand high impact combination HIV prevention for key populations, adolescent girls and young women, and young men in all their diversity. I was speaking earlier to a group about this issue and saying that we have high impact combination HIV prevention strategies, but we also have programs that are designed to confront these issues of gender-based violence and teenage pregnancy, and you know, all those challenges that affect the adolescent girl and put her at risk of HIV. And so we need to expand even the combination HIV prevention to be able to actually take into account what we need to do here. Here we have seen excellent work by other partners, the gender equality community, for instance, the he for she work that is investing in men, investing in changing the behavior of men who very often are perpetrators of intergenerational transactional relationships that drive some of this HIV, working with men in their leadership roles, looking at issues of harassment in the world of work. These are important initiatives that exist across partners beyond our work at UNAIDS, with partners, even with other UN agencies in other sectors of the government that go beyond health, our gender, our social protection, economic sectors to make sure that we're driving for real addressing of these structural barriers. We need to preserve gains in testing and treatment, and I talked about that, to be able to focus on the coverage and the gaps of those communities that are left behind. That we ensure the sustainability of the response, including through greater domestic funding and service integration. I talked about the structural barriers and addressing harmful gender and social norms. And finally, empowering communities and placing them at the center of national and subnational HIV responses, striving to tailor our HIV and sexual and reproductive health and rights services to the needs of young people in all their diversity, thus ensuring higher services uptake. If we don't act now, many lives will be lost, but containing the AIDS pandemic is more difficult and more expensive in the coming years. The prevention agenda is a hard agenda. It is an agenda that we started when we didn't have any treatment solutions. We did better before. We need to go back and remember what it is that we did that we can bring back and enhance so that indeed we're able to contain this AIDS pandemic by 2030. Ending AIDS is achievable. There are tested sets of approaches that are proven to work, including in challenging settings. By including communities, they are on the ground and they play an integral role in connecting us to the services and connecting people to services, in supporting the governments to deliver services where it is even harder to reach. To increase investment in prevention, in testing and treatment, in sustainable domestic financing, both to prevent and to treat HIV, and to build stronger health systems that protect the right to health and lead us to a pragmatic version of pandemic preparedness. To address the inequalities driving the epidemic, including education for girls and boys, and reforming laws that are discriminatory. Scaling up the implementation of the global AIDS strategy that has been aligned to the Uganda HIV strategic plan will be for us an excellent solution in ending inequalities to end AIDS. Thank you for this opportunity. Back to you, Program Director.
Thank you, Anne. Thank you very much for an exhaustive presentation. Dear participants, we now go to the next session. We had already indicated that the status of COVID-19 in Uganda has been deferred to tomorrow. And for those of you who are hoping to have a break tea now, will unfortunately miss it because we had it before. So we'll go ahead and listen to the next presentation by Dr. Watiti, the chairperson of NAFO-FANU. Dr. Watiti is going to make his presentation online, and he's going to talk to us about HIV and COVID-19 among people living with HIV/AIDS. And we are told Dr. Watiti is already online, so please go ahead, Dr. Watiti.
I thank you, Chair, for the opportunity. I couldn't join you physically, although I would have loved to be there, but of course of some challenges along the way, I decided to see, but I hope you can hear me. And I had shared my slides earlier. I don't know whether they can be able to be screened. Yeah. Thank you very much. Thank you very much. I'll remove the video to try and maximize on the connectivity. But as you know, people living with HIV have, like all of us, been affected by COVID. And in Uganda, the population of people living with HIV, as most of us know, is over 1.4 million, and about 1.2 of us are on treatment, for which we are grateful to God and the government for. And the National Fund is the National Forum of People Living with HIV Networks, which is an umbrella organization covering most of the districts in Uganda. We are in over 135 districts, and we have about 13 national networks which are specific cohorts of people living with HIV, both men, women, young men, teachers, religious people, and people, members of the armed forces, the police, army, and the prisons. And our vision is people living with HIV being able to live a quality and productive life in a sustainable manner. Now, with the coming of COVID-19, we don't of COVID-19 and the lockdown in March, which was quite unexpected, this was caught many of us unaware. As you can imagine, there was a lot of disruptions, but we are grateful to the Ministry of Health, the AIDS control program, for the guidelines that they gave, of course, for COVID, but also for HIV. And this was among especially the importance of us continuing to access ARVs. Many people got ARVs from nearby health facilities. In spite of the challenges, for example, many were given just 1 month, which means you have to go back. Some people faced extortion. We have had people report that some of them were asked to pay money. Others were given wrong combinations because they did not know what they were on, and the people who were helping them were at a loss also. As we noticed, new kid on the block, COVID took the center stage, and HIV and other existing diseases seem to have taken a back space, but we are picking up, So the HIV and COVID-19 in Uganda, of course, you know, there were travel restrictions. Both the lockdowns, first and the second, had impact on us because of travel restrictions. They have food shortages because many of our people, especially in urban areas, really people who live hand to mouth. And many of these did get challenges. Some of them stopped taking ARVs. The issue of stigma keeps coming up, although we have done a lot to erode stigma. It still is there. And you know, these people, many times, you know, you had to get a letter from either the LOC1 and you have to tell them why you're going away. And you disclose the disease, which was forced disclosure in a way. We've seen also the importance, I mean, the fact that many people were illiterate. People don't know their medicines. Many people just describe their medicine by color, by shape. And so when they go for these refills, many of them have not had the good quality care which as it used to be. The stress also caused by the epidemic, the fear of death, and mental illnesses have been on the increase that we've seen many of our people get especially depressed. Many of us lost employment, and which was a means of survival. We did a study amongst us of about close to 482 people, and many of them were affected by travel, the travel distance. We have been encouraging people to get registered to nearby facilities. These facilities are in almost every county, every nearby health centers. And many people, you will not be surprised to find somebody living in West Nile and getting their treatment in Kampala, and people living in Kampala and getting their treatment in Kapiripirit for various reasons, as you can imagine. Of course, many of them did not have transport. Many refused, they were able to go out, but refused to go out because of fear of exposure to corona. And some few places experienced stockouts, but these were mainly because some people converged on certain clinics, and some clinics were not being, were not serving as many people as so you can imagine there were stockouts. But this was, again, well handled, I believe. The cost of some medicines that some who, for example, are on with comorbidities like diabetes and the high blood pressure. Now, many of these, of course, had faced those, and stigmatization, which I've already alluded to. So what are the major needs of people living with HIV? And we did this, and we found in this, people living with HIV during the COVID, we did a survey And those are the figures. About 630 people were surveyed in about 101 districts. About 54 were female and 46 were male. But almost all correspondents identified the need for provision of food. We still have food insecurity amongst our people, and people living with HIV need food. It should be actually treated as part-on treatment. People who are on medicine every day cannot afford not to eat. Many of them also had issues of masks and PPE for those who are especially health workers. But this way, general, but of course, many people, the masks, they didn't come in time, and others didn't have enough time to manage. Neither also the knowledge to use them. However, we try to ensure that there are consistent supply of ARVs, at least for 3 months. Most people did get this. Others even need psychosocial support. Many people faced domestic violence, as you can imagine. The fact that many people who were not at home ended up being incarcerated sort of at home. And many of them were not receiving counseling services, which they normally got from what? And then other things which were needed were family planning services. Many have ended up with unplanned pregnancies and the increase of gender-based violence. Of course, we lost quite a number, but of course, because of stigma, again, many of the people living with HIV who died could have been COVID, but of course also the effect of AIDS. The AIDS-related deaths didn't stop just because of COVID. But of course, when a person living with HIV who is not open dies of the diagnosis will be COVID. But many of them, some of us got COVID, but we recovered, was thank God. But the good news is that there are many people who did recover, and many are getting vaccinated. Although because of the misinformation, some people have feared to get vaccinated. Some of us went out to get vaccinated and even went public with our pictures of being vaccinated, hoping we could inspire others. And we encourage all people to adhere to SOPs for containing HIV. Incidentally, people living with HIV should have found this, because we are used to restrictions, we're used to issues to do, for example, condom use. So this use of masks should have been easier, but learning new habits is not easy.
Dr. Wadita, are you there?
God, no, I'll finish. There being a cycle of hope. Given, and the people encouraged to go and get vaccinated. And to counteract these fears, we have engaged with people like Professor Nantulia, who is our patron. We've held a few meetings, Zoom meetings, and encourage people to share this. And out of about 900 people had been vaccinated. Only about 10% have been vaccinated. So there's still a lot to be done among these. So what have we done as Nafufano? We participated in the formulation of Ministry of Health COVID-19 HIV guidelines that have improved, especially service delivery. We have had representations on the Ministry of Health COVID-19 task force. We formed the WhatsApp groups and being able to share information in real updates, being able to encourage each other online and encourage others who may not be able to access WhatsApp. We do share this. We are also been part of Ministry of Health, COVID-19 WhatsApp group with partners, people who have been giving us the drugs. There have also been food distribution. I think we should be on the next slide, which the support from the Embassy of Ireland, households in Karamoja, Aid Fund, and UNAIDS. Unfortunately, this, of course, couldn't go very far, and many people did not receive the medicine that as a ward. We also shared hygienic packs, which were given to us by UNAIDS. We have a toll-free line, which again is support from UNAIDS, has been helping people. And also lobbying some IPs to do home deliveries, and some have done. A lot of work has been done using this. We have held media talk shows, like radio, TV, and other social media, and even using megaphones in the villages. The the radio talk shows seem to be the most popular. I participated in one of them, a few of them, and many people called back, which means they were listening. We also do thank God for our people living with HIV champions, who sometimes even rode their bicycles or even walked and delivered medicines for others. We do appreciate this. We did community mobilization and sensitization, which has continued, the media engagements and integration, and we also advocated for integration of this care into other medical programs, and also advocated for livelihood support programs, because as you note, people living with HIV, many of them are not doing very well. And we also work with existing networks and community structures, which many of them need strengthening. These structures are there, but they need strengthening because many of them don't have very good management. We also been communicating on using especially mobile phones. Many people living with HIV have phones, but this needs money. So we mainly need support for this. We encourage people to continue, people living with HIV to access treatment, TB prevention services, because you know TB is the biggest killer, and also to be cared for those within diabetes and high blood pressure. I've had issues.
Seems there are network issues. Dr. Watiti, can you hear us?
Hello?
Yes.
Okay, I was finishing. I was mainly raising the issue of the breakdown, especially in some people not accessing that treatment, but a few who are on third line. And we are trying to see whether this may need the policy at the ministry to change this to another more available regimen other than keeping them on this one, which is not. We also request for support of people living with HIV structures. We believe that treatment for life should be treated like driving, which means you should have your license renewed. So this should be given regular treatment literacy engagements. That means the HIV program should budget for treatment literacy to accompany this. We also, of course, do appeal to the Prime Minister's office that people living with HIV who are in a very part of this country and they are already registered when it comes to issues like food distribution, they should be looked at without having to make them register again because they're already registered at the ART centers and this one need the food. I think those are the few ideas that we have, but generally we thank God that many of our people have continued to get services in spite of the hiccups. I thank you very much.
Okay, thank you very much. Thank you very much, Dr. Watiti, for really your message of hope for everyone. And now we want to proceed to the official opening. We are still expecting the Right Honorable Prime Minister of the Republic of Uganda as our chief guest. And anytime we should be starting the opening ceremony. But allow me officially to welcome the Honorable Minister for Economic Monitoring. It is a pleasure to receive you here, and thank you very much for putting in your time. You are warmly welcome. The representing the Minister for Presidency, who is the host minister actually for this function. So I would like now, as we wait for the arrival of the Right Honorable Prime Minister, we should have a music interlude for about 10 minutes, then we shall go into the formal opening ceremony. Thank you.
Stigmalist band. Ladies and gentlemen, the group you're about to watch is called Stigmaless Band. It's a group of Ugandans living positively, living with HIV. It's a bigger group, but because of COVID, we brought a small number. And I'm called Moses Supercharger, their leader. I'm a person who has lived with HIV for the last 30 years. 30 years, 3 decades with HIV, but I'm healthy and doing good. All the sessions we are talking about, people not retaining into treatment. People are not adhering. We are doing very well in the first 90, not doing very well in the third 90. Doing very well, Dr. Msova comes say we are doing very well in the first and second, not doing very well in the third. Another one comes, says the same thing. Yeah, another one comes and he says the same thing. So the biggest problem is the third 90, which is us, basically. Imagine somebody picks the medication from the hospital. Somebody goes for HIV test first and foremost. He's tested. Then he picks the medication from the hospital. He goes home and does not use them. What is the problem? And they are telling us majority of these people are these ones, the younger person. Maybe let me ask one of these younger person. Tell us what is the problem? Why do you pick medications and don't utilize them properly? You are the ones failing us to reach the third 90. What are the problems? The ambassador is hearing you now. Quickly, tell us.
One is lack of regular treatment literacy among people living with HIV. Another one is poor adherence support programs. We don't have adherence support programs, especially for the young people. Then the other one, the biggest, is stigma and discrimination. It's sad that in the 21st century we are still dealing with stigma and discrimination. And psychosocial, we don't have enough psychosocial support programs.
So in other words, we are just putting people on treatment and don't support them to take the medications. Wasoma. We need adherence. The next song is called Adherence. The adherence does not only mean for people living with HIV, but even you, the health workers, you must adhere to your job. These days, folks are going to pick Lutaya and you are telling them it is not in clinic. You are not adhering. Stock out. You are not adhering. So the next song is called Adherence is the Key to Success. Take your drugs and victory will be yours. HIV is a loser, I am winner. I take my drugs. That's why I'm looking cool. Give me the song. We are given only 10 minutes. Give me the song Adherence. Give me the sound. Bass. Bass is here. Adherence is the key to success. Take your meds and victory will be yours. HIV is a loser winner. I take my meds, that's why I'm looking good. Songa mbere, songa mbere mbere nze, songa mbere, songa mbere, songa mbere, songa mbere mbere nze, songa mbere, songa mbere. PMT City.
To produce a good and healthy child.
I use a condom
When I'm having sex, to protect my life and protect other people's lives. Songambele.
Adherence is the key to success. Take your meds and victory will be yours. HIV is a loser winner. I take my meds, that's why I'm looking good. Songa mbere, songa mbere mbere nze, songa mbere, songa mbere, songa mbere, songa mbere mbere nze, songa mbere. Olegera manyi ga RV? Ah.
Early treatment is the key to success.
Early treatment.
Better test your blood and get to know your life.
Positive living.
Is the key to success. Better take your meds and victory will be yours. Songambele.
Adherence is the key to success. Take your meds and victory will be yours. HIV is a loser winner. I take my meds, that's why I'm looking corner. Songa mbere, songa mbere, songa mbere. Say it louder. Uganda. Songa mbere, songa mbere. Is the key to success. Take your meds and victory will be yours. HIV is a loser winner. I take my meds, that's why I'm looking good. Songa mbere, songa mbere mbere, songa mbere, songa mbere, songa mbere, songa mbere mbere nze, songa mbere, songa mbere. Adherence. That's a song, Adherence. Okay, before you go, okay? We want to give you another one, a quick one. It's a scientific one. You know, one of the reasons why people are not taking medications is being in the state of hopelessness. Some people are there, tebalina hope. But as a person who interacts with Dr. Musoba, Zibanyabo, but doctor, we see a lot of interventions being done in research, especially in the field of cure. One of the things that has kept me going the 30 years I've lived with HIV is knowing that somebody is there and is caring about finding better options. 25 years ago, we didn't have DTG, which all of you take these days. But because of research, we have it, isn't it? When I was switched to treatment in 2000, I was given 7 huge tablets to take. In 2000, huge. And they told me to keep them in a fridge, which I didn't have. But these days, I'm taking 1 tablet, and I'm not keeping it in a fridge. So because of research, we have better what? Interventions. So people living with HIV, don't lose hope. Keep taking your medications. Better things are coming. Did you know that right now, the world is investing $500 million into finding an HIV cure? And last year, but one, United States government, through NIH, gave
$200 million just for cure of HIV using gene therapy. And next year, Uganda will be the first country in Eastern Southern Africa to first do a gene therapy clinical trials to cure HIV and sickle cell. Can you imagine? So we are not saying the cure is coming tomorrow, the next year, but even if it comes after 10 years, it will only find me who is adhering. So if it comes after 10 years or 20 years, it will find me supercharger who is adhering. If you are not adhering, it will not find you. So stick to your medications. These medications are very expensive for the people who are buying them for us. 90% of the medications we use are bought by America. They also have problems. But they sacrifice and buy these medications and then you don't take them properly. Shame upon you. The cure will come. Be optimistic. Give us the song, Optimistic. It's a freestyle. Just express yourself that the cure will come one day. Let's be adhering. Give me the song. Optimistic. Let's go. Optimistic. 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 HIV cure will
setting me free. I lost my daddy in September to HIV/AIDS. I'm tired and weak.
The orphan is struggling with medication, and the cost of the drugs is too high. I want my freedom. That's why I'm searching for the HIV cure.
I wanna get married without the fear of infecting my mind.
Optimistic, optimistic. HIV cure will be coming one day. HIV cure will be setting me free.
Love and love, all shock and kill. I welcome anything that comes my
Block
way.
and lock shock.
I want my freedom, I want my joy.
I want my holiday. The uncertainty, the indignity will be no more. HIV cure will be coming one day. HIV cure will be setting me free. Denied a visa for your travel. Too bad. Therapy, gene therapy.
I welcome anything that comes my way.
Whoa, whoa. HIV cure will be coming one day. HIV cure will be setting me free. Optimistic. HIV cure will be coming one day. HIV cure will be setting me free. Yeah, thank you so much. Before we go off stage, Your Excellency, I want to show you this young girl. I met this young girl when she was 6 years. She's a young person living with HIV. The cameras, please don't show this kid on TV. Help me. Just this particular part. Her mom and daddy don't have HIV, but she got HIV. Around 4 years, she fell very sick. She was taken to hospital to get blood, and she was given bad blood. So she got HIV because of that. The brothers and sisters, mom and daddy don't have HIV. She's the only one with HIV in the family. Why did I bring it out? Parents also have to be very careful with their children when it comes to treatment. We need to take care of these children. When it's blood, make sure it's a good clinic. May God bless you. Thank you, Uganda AIDS Commission.
We are now proceeding to the official opening ceremony, and In a short time, we shall invite Your Excellence, the Honorable Minister, and the Chairperson of AIDS Development Partners to join us in front here for the official opening ceremony. You are warmly welcome. We are expecting the Prime Minister to sit here. AIDS Development Partner, Honorable Minister, and Your Excellency. Here at home. We are reliably is ready there to lead us through the anthems, both the Ugandan.
Tuwajibike, tuimarike, umoja wetu ni nguzo yetu, idumu jumuiya yetu.
We can sit down. The Right Honorable Prime Minister, in your absentia, the Minister for Presidency, Your Excellency, the American Ambassador to Uganda, the Chairperson of the AIDS Development Partners, it is a great pleasure to have you at this function. I want to thank all of you for coming to join us at this great conference as we share experiences on HIV and also look at, take stock of what achievements we've made since we started the fight. I would like to thank all your agencies, your governments, for all the support you've been giving to the Republic of Uganda in this fight. Let me take this singular honor to invite the Chairperson of the Development Partners to make her remarks. Thank you.
Permit me to take off my mask. I'm fully vaccinated. And if you are not, please go get vaccinated. My name is Adeke Mindieli, and I am the head of office, acting head of office for UN Women here in Uganda. The Right Honorable Prime Minister in absentia, the Minister for Presidency, the US Ambassador Natalie Brown, civil society organizations present, people living with HIV present and online. I am here and I stand to represent the AIDS Development Partners Group. Some of us are here in the hall and others are online. Ladies and gentlemen, I take this opportunity to welcome you all physically present and online to this national HIV meeting featuring the Joint AIDS Review and the Philly Lutaya Memorial Lecture. I thank you, HIV and AIDS pandemic continues to be a global public health issue. And developments concern affecting all sectors while deepening the burden to be borne by the health sector. Without a doubt, COVID-19 outbreak and its containment measures experienced throughout this period and throughout the world under the review came with unprecedented challenges, and now, as we recover gradually, it also offers extraordinary opportunities to build back better for the service delivery systems and communities. I therefore join and re-echo the applause for the great strides that have been attained by UAC and all development partners, as well as all community members that have contributed to the HIV response in the last few years, and also addressed the issues of vulnerability and exacerbation of COVID-19. The last 20 months have been quite challenging and characterized, amongst other things, around the outbreak, and the impact has been immeasurable. Uganda experienced a breakdown in social security and protection systems, health services, loss of economic livelihoods, escalation of violence and crime, and social service institutions became dysfunctional. For the first time, as much as we can remember, there is no debate to the fact that progress made in containing HIV epidemic has not kept the pace with the realities that populations at risk and populations living with HIV need. In fact, in many circumstances, this has been rolled back, and it is beginning to make programmatic sense that there are structural, economic, and social barriers that continue to hinder progress in all our efforts aimed at containing the pandemic. The majority of these barriers manifest as HIV treatment complacency, as you heard from the young people here today. Failure of antiretroviral therapy, loss to follow, increase in sexual gender-based violence, teen pregnancy, and I say again, teen pregnancy, because as we know, I mean, when you get pregnant, it means you have been exposed to the body fluids, which again is a high risk of transmission of HIV. This has been quite challenging for Uganda. While it is true that Uganda has made marked progress in the 4 thematic areas of the national response, with impressive overall results of about 60% and above, decline in new infections and HIV-related deaths amongst men and women, 15 to 49 years. And by the way, there's a statistic that says all women between the ages of 15 and 19, 1/4 are pregnant in this country. 1/4 of every young girl between the ages of 15 and 19 are pregnant. That is alarming. Ladies and gentlemen, for instance, adolescent girls and young women 15 to 24 remain a population of concern in terms of absolute infections and inequalities that hinder the adoption of HIV prevention behavior and effective survival with diagnosed HIV infection. Some are failing on treatment for HIV and registering poor adherence averages and very high viral load, especially on the maternity platform. Social safety nets, health and other social services, delivery systems and coping mechanisms have been disrupted by COVID-19 pandemic. A delay to provide medium to longer and long-term strategies and options may send thousands of young women and adolescent girls into extreme vulnerability and increase their risk of infection that will consequently jeopardize their future inevitably. The 2021 Joint AIDS Review makes some valuable immediate, medium, and long-term policy and programmatic recommendations for refocusing the national HIV response and what is lacking in the bold emphasis on ending inequalities, including addressing the barriers of effective HIV prevention, AIDS treatment, and failure of institutions and systems to address the needs of people living with HIV, especially the populations at high risk of new infections. As AIDS Development Partners Group, we are optimistic that this gathering will recommend targeted think tanks to generate strategic recommendations that would inform high-level decisions and advocacy for intensified implementation of combination HIV prevention interventions that are tailored to the local HIV epidemiology. And I was happy to hear about the gene therapy that was going to be first tested here in Uganda, and that is quite exciting. At this point, I want to draw our attention to the National Investment Plan that recommends a prioritized scale-up plan where new infections are projected to decline and reach 15,000 by 2025, while AIDS-related deaths will decline to 10,800. Every single life that is lost is one too many. These targets call for more innovative ways of addressing the co-founding factors of HIV risk and vulnerability, especially amongst the priority populations. A reflection of the elements of the national HIV response using an inequality lens and other parameters along with prevention cascade could help identify additional barriers that, if not addressed, may derail timely attainment of the country's set targets and commitments for 2025. On behalf of the AIDS Development Partners Group, I pledge our continued and renewed commitment to support the country's efforts on this cause. It is also important to bring the right actors on board, and we heard that also resonated by the regional director for UNAIDS. A shift from the promises to action is dire. It is urgent that Uganda begins to transition from donor financing for vertical HIV prevention programs and projects to more integrated development and social service interventions that strengthen governmental ownership, promote the role of civil society and communities to deliver requisite HIV prevention, treatment, care, and support services. The multi-sector card remains a key strategy in sustaining the national HIV response. It is truly time to acknowledge the role that inequalities reflected in education, attainment for boys and girls, young people participating, poverty, decision-making for men and women, sexual reproductive health choices for PL-HIV, and coverage of combination prevention interventions, level of government investment in HIV response, all of which have been playing and will continue to play a major role in sustaining the response in this country. As I wrap up, I would like to share with you a call from all AIDS Development Partners Group to Uganda AIDS Commission, the Ministry of Health, as well as communities. To Uganda AIDS Commission, our call to you and our demand today is to provide clarity, tools, and guidance for coordinating multi-sectoral actors at the risk of sounding obvious. No partner can do it alone. Non-discriminatory platforms for engagement of all partners remain critical. We must invest significantly in robust sex and age disaggregated data, along with other critical data sets, as well as gender and intergenerational analysis that has become so critical today. Of all these data sets, to provide evidence on what works and what remains key ingredient of the incentive for investment. Number two, for Ministry of Health, we call on Ministry of Health to be more creative and scale up models that promote sustainable participation of all individuals that requires specialized care, cognizance of the context, possible barriers to continued participation in HIV care programs, and take critical data generated into consideration in planning and decision making. And finally, to communities and to people living with HIV, to mobilize and be better organized and collectively promote effective HIV prevention, treatment, and care interventions across all levels. It is not enough to demand for accountability. We are not accountable when we are demanding for accountability and are not accountable ourselves. As I conclude, permit me to remind us that while COVID-19 presents a twin challenge to HIV, therein lies, and I would have to say the third one being gender-based violence, therein lies a promising opportunity to showcase our collective resilience and address the extreme and intersecting vulnerabilities that continue to put our people at risk of poor health and less productive lifestyles. On behalf of the AIDS Development Partners Group, I welcome you all to this very important conference and wish you happy deliberations. Thank you.
Thank you, Chair of the AIDS Development Partners. Another big clap for her, please. Thank you. Your Excellency, Ambassador Natalie Brown, we thank you for your patience. We thank you for having come on time. Today we have been super efficient and we've gained a lot of time, but we are still waiting for the guest of honor, the Right Honorable Prime Minister, and we beg your indulgence, Your Excellency, to give us a few more minutes while she comes. Honorable Minister, we thank you for coming on time. We beg your indulgence as we wait for the Honorable Prime Minister. Meantime, I'd ask the young people and the groups to give us more messages. These are actually not entertainments, but they are messages of hope. They are messages of us to support more of what they are doing, and especially how we can reduce stigma in our communities. So thank you, Excellency, for your patience. Supercharge.
Faster. Faster. Ladies and gentlemen, the last song we are going to present to you is called Say No to Resistance. Say No to Resistance. And since the guests are there, which are from here, say no to resistance. There are two major causes of HIV drug resistance. The first one, and the major one, is poor adherence. You know what I want? To me, as a man, so there are two major causes of HIV drug resistance. The first one is poor adherence, and the second one is transmitted resistance. Why am I bringing this? There is a feeling and saying among the people living with HIV that I'm already infected, I don't need a condom. You need a condom to avoid transmitted resistance. The reason why I can't do sex without a condom, because I don't want transmitted resistance, which will jeopardize my medications. I'm on second line. I don't want to meet somebody on the third line, on last option. No way. So people living with HIV, you need a condom as like a negative person to avoid resistance. Say no to resistance. Give us the song. I am a mama, I am a mama, I am a mama, say no to resistance.
My country, Uganda, has the highest rates of HIV drug resistance. Like 100,000 people are not virally suppressed. Aye, mama, aye, mama, aye, mama, say no to resistance. Aye, mama, aye, mama, aye, mama, say no to resistance. Calling nations and people to fight with zeal to stop HIV, drug resistance. Policy makers and funders provide a third line. Never give up on people who are failing. Watoto wanalia, wabibi na wabwana wanakufa, shida ya resistance. Sasa tuyende wapi? Maskini tufanye nini? Tunaumwa, mutupatie dawa. Let's go. Aye mama, aye mama, aye mama, say no to resist. Gloria. Aye mama, aye mama, aye mama, say no to resist. Vanessa. From Uganda AIDS Commission. Ani agati abasawo tebakumanyi. See someone you love. Voice make a healthy worker. Sasa tuyende wapi? Maskini tufanye nini? Tunaumwa, mutupatie dawa. Fena. Aye mama, aye mama, aye mama, say no to resistance. Say no to resistance. Aye mama, aye mama, aye mama, say no to resistance. Next. Ayagala resistance yabasigala mu ntebe. To boost adherence. Listen, let us do viral tests as we demand genotype tests to evaluate drug resistance. Let us do viral tests as we demand genotype tests to evaluate drug resistance. Aye mama, aye mama, aye mama, say no to resistance. Aye mama, aye mama, aye mama, say no to resistance. Vena, South Africa, Angola, Botswana, Lesotho. Aye mama, say no to resistance. Mozambique, Uganda, stand up. Malawi, Tanzania, stand up. Aye mama, say no to resistance. Namibia, Kenya, Rwanda, Burundi. Aye mama, say no to resistance. Zambia, Zimbabwe, Nigeria, Ghana. Aye mama, say no to resistance. Aye mama, aye mama, aye mama, say no to resist. She's the worker of Uganda AIDS Commission. Aye mama, aye mama, say no to resistance. Woo! Thank you so much.
With the support from Uganda AIDS Commission last year, but one, we recorded this song. It's audio recorded. And we lack a video. So anybody out there, if you want the song to be recorded visual and put on this television, please step up. US already stepped up for the audio. Give us the song.
Prevention of HIV, prevention is solution number one. Our leaders, young people and elders, prevention must be the golden rule. Let them know, hey chimala chimala, hey chimala chimala, hey chimala chimala, stop the suffering. Hey chimala chimala, hey chimala chimala, hey chimala chimala, stop the misery. We are facing new infections every day. Mortality in Makonde striking hard. The burden is alarming in Africa, and funding for the service slimming down. I'm calling on my people wherever you are. Let us step up the pace to stop new infections. Prevention of HIV, prevention is solution number one. Our leaders, young people and elders, prevention must be the golden rule. Let them know, hey chimala chimala, hey chimala chimala, hey chimala chimala, stop the suffering. Hey chimala chimala, hey chimala chimala, hey chimala chimala, stop the suffering. Hey chimala chimala, hey chimala chimala, hey chimala chimala, stop the misery. Listen. We can end HIV by 2030 if we all use the following interventions optimally: structure, behavior, and biomedical in combination. Condom, PrEP, task, and circumcision. I'm calling on my people wherever you are. Let us step up the pace to stop new infections. Prevention of HIV, prevention is solution number one. Our leaders, young people and elders, prevention must be the golden rule. Let them know, hey chimala chimala, hey chimala chimala, hey chimala chimala, stop the suffering. Hey chimala chimala, hey chimala chimala, hey chimala chimala, stop the misery. Prevention of HIV, prevention is solution number one. Our leaders, young people and elders, prevention must be the golden rule. We said my last one. Hey chimala chimala, hey chimala chimala, hey chimala chimala, stop the suffering. Hey chimala chimala, hey chimala chimala, hey chimala chimala, stop the misery. Prevention of HIV, prevention is solution number one. Our leaders, young people and elders, prevention must be the golden rule.
Temuvaako tukoledera akasembera ddala bakaita hear her cry. Microphone eno mutabani. I don't want to hear that. Put it down. Okay, this is a song called Hear Her Cry. We are fighting against gender-based violence. In the first lockdown, 6,000 young girls were raped in one district of Moroto. 6,000 young girls below the age of 18 raped by we the men.
We must say no to this because it's one of the causes of new infections. Give us the song quickly before the chief guest comes. We did it with Uganet. Put your hands together for Uganet. And Tasso. Here if you don't want GBV, show some life. This voice is calling you for the rights of young women and girls. Tetuba tulugunya nabo bantu tubalekere bambyedembe yawe. Hear her cry. Representative of people living with HIV on CCM. This voice is calling Christ for the rights of young women and girls. Tetuba tulugunya nabo bantu tubalekere bambyedembe yawe. Hear her cry. Uliro kaba kwe tubadde kyabami lwaki tweyisa ng'ensolo okutulugunya omukyalo omuwala ekyo kive nnyo musange wa Katonda ne mu kkooti gwa Naggomola omwana gw'otulugunya fyuca yo gisudde mu nnyanga kikomye leero kwe kikomye leero. This voice is calling you for the rights of young women and girls. Tetuba tulugunya nabo bantu tubalekere bambyedembe lyabwe. Hear her cry. This voice is calling you for the rights of young women and girls. Tetuba tulugunya nabo bantu tubalekere bambyedembe lyabwe. Hear her cry. Kona my boss, Lillian. Ab'obuyinza mu ggwanga n'abazadde muwulire bino kibakakatako okugwa gabava yonna gy'obeera temubikkirira misango mubatwale bawonyezebwe va mu kulya enguzi bulamu bwa muntu bw'ozannyirako kikomye leero. This voice is calling you for the rights of young women and girls. Tetuba tulugunya nabo bantu tubalekere bambyedembe lyabwe. Hear her cry. My beautiful one Lilian Moreko bale mukubireko mugalo zize nowe wange. For the rights of young women and girls. Tetuba tulugunya nabo bantu tubalekere bambyedembe lyabwe. Hear her cry. This voice is calling you for the rights of young women and girls. Tetuba tulugunya nabo bantu tubalekere bambyedembe lyabwe. Hear her cry. Thank you so much. Thank you, Lydian.
Thank you, Supercharger, for those messages. I am sure many of these people have heard them loud and clear, and we want to go back as your ambassadors in spreading these messages. When you hear that 6,000 young girls in Karamoja were defiled, that's terrible. I don't know what else to describe it. How else one can describe it? Let us all put our hands together for Supercharger and all those who supported them, Uganet and Tasso. Thank you very much for supporting these. These messages are extremely, extremely important. With the support of the American people, we are supporting populations in Karamoja, where Supercharger has just told you that gender-based violence is extremely high, and we are looking for partners like these people to go and reduce stigma in those populations. This is not on the program. I also want to request for your patience for a slight modification in the program to bring forward one of the presentations we are going to have later on by the acting country representative of UNAIDS. Josa Mubanjizi is going to talk to us about the UNAIDS framework. Apologies if I have called it the wrong name. You'll correct me when you come in. Excellency Ambassador, Honorable Minister, once again, thank you for your patience.
Thank you very much, the Master of Ceremonies, and Your Excellency, Honorable Minister, and the Chair ADP, the country. Thank you for this opportunity. I will highlight the key areas within the Global Aid Strategy. My regional director, Anne, was able to go more into the details of it, so I will highlight a few slides and share with you, highlight the key focus areas, and then we'll be able to move on. I'm Josa Mubanjizi, the acting country representative for UNAIDS in Uganda. In June 2021, the UN member states of which Uganda country is met in Geneva, adopted and approved the political declaration. The political declaration calls for end of inequalities and end of HIV and AIDS. And member states committed that they would be able to commit resources, political commitment, coordination such that it can be able to end HIV and AIDS. This was informed by the dire need that we could not meet the 2020 targets. And also to note that HIV and AIDS continue to remain a pandemic and affecting many people, and worse off in Eastern Southern Africa, Uganda, South Africa, and Nigeria being the highest hit. The 2021 political declaration is a commitment of which the member states are required on an annual basis to compile the status of what has been done, to be submitted to the UN Assembly on what has been done, what are the key milestones, what are the key challenges, and what are the key actions. Today's joint annual AIDS review is one of those key milestones that will be able to compile and be able to update the member states in the coming years. The 2021 political declaration basically regrets that we could not be able to achieve what was set to be done. And basically that while we've been able to do well in terms of treatment, we still struggle with areas of prevention, and those are accelerating new HIV infections. We still struggle with inequalities around issues of gender-based violence, around issues of stigma, around issues of human rights abuses, and those we cannot achieve even the 2025 commitments unless those are addressed. And therefore, member states did commit that, yes, going forward, they'll be able to put forward and declare on that. I'm humbled that Uganda AIDS Commission, under the leadership of the team, have been able to look at the global AIDS strategy and the global commitment and be able to customize them within the National HIV Strategic Plan, which will inform the action plan for the coming implementation. Ladies and gentlemen, Anne, my regional director, talked more around this. The focus for Uganda will basically around while we focus on the 95, we are almost there, but we are doing well, badly in terms of the addressing the 10-10, addressing the issues of human rights, addressing the issues of inequalities. but also addressing the treatment targets for the children, men, and the key population. The key messages that I want to highlight as I remain with the slide towards the end is that there have been progress and Uganda has done well. And I think if you don't mind, you can put hands for Uganda. Uganda has done well in terms of being one of the 8 countries globally to achieve the 1990. But we still don't know the inequalities that center around the children, young women, and also the key population. We also took note of the issues of the COVID that has come at play. But also the other challenges that where Uganda, while we've done well, the unfinished business centers around that Uganda is one of the few countries, around 17 countries, that continue whose demand for family planning is still low. And we cannot talk about end inequalities and AIDS unless we address the issues of family planning, unless we address the issues of condom access to the last mile. We cannot talk of ending inequalities and AIDS unless we talk about addressing and ending TB. To take note that progress is still low, especially in the country, Uganda, on achieving the TB-rated targets. And I think we can be able to do more around that area going forward because we cannot move far. We are grateful globally and in the country and in East and Southern Africa that we've been able to do well in terms of reducing vertical infections among the children. But Uganda is among the few countries where the newborn babies are we still have about 5,300 babies born HIV positive, despite the science that we have. And I think we need to address that, because if we don't address that one, then these young babies, innocent as they are, we have to sustain them until their arrivalhood. And Uganda, we can do better on that aspect. Lastly, issues of stigma, of violence and discrimination. Uganda again was among the countries, basically among the 11 countries globally, that reported high levels of violence. They centered from all circles of physical, sexual, and emotional. And that is not good. If we have stigma, if we have violence at home, in school, in the workplace, then we cannot talk about ending inequalities, and we cannot end AIDS, and then the epidemics will keep calm and erode the good gains that we have been able to do. And lastly, to note that Uganda still struggles in terms of financing being externally, and Honorable Minister, we still call upon the Republic of Uganda. I know Uganda AIDS Commission have come up with the mainstreaming guidance, but we need to see how we can be able to take to ensure that the 1.3 million people living with HIV, at least have close to 90% covered by the government. I think it is something that we need to think about. As we invest in roads, as we invest in infrastructure, as we invest in agriculture, I think we cannot talk about 1.4 million people living with HIV that continue to be finally externally financed. The last slide I want to talk about, which was talked about earlier, as I try to end my presentation, is that we still struggle with seeing high infection around the 15-24. And this has been worsened worse by the COVID, and we are yet to see more impact. And therefore, we need to ensure that we promote and scale up and support intervention where we can empower girls both at home and in schools, where we can ensure that adolescents and young girls continue and remain in schools and are sustained in schools. That is a sure way of ensuring that we will protect them. But also similarly, we need to ensure that the boys, while the girls you may witness a pregnancy, you will not witness a pregnancy on the boy. And that does not mean that the boy is well. But it means there could be issues of drugs, there could be other issues. There could be the same boys that are impregnating the other girls. So we need to ensure that we do that. This is my second last slide to say that we are still can do better. And as the partners here and those online, we can do better. Registering about 370 HIV infection is not something that we can be able to be happy with weekly. Having 8 out of 10 new infections among the girls 15-24 is something that we should not even talk about. We must wake up and move out of the boardroom and go into the community and address the issues. Having 100 babies innocent, one born HIV positive, is a crisis, because going it every other week, then it means we'll be in a huge crisis. And the issues we see why the babies are born HIV positive is basically that the mothers start on the treatment rate. Is it because that the mothers drop on the treatment? Is it because that also they don't access treatment in timely? And therefore, issues that Supercharger was presenting about issues of literacy, treatment literacy, is extremely important that we're going to be able to break through. As I end the Master of Ceremony, Excellence Ambassador, Honorable Minister, and the Chair of Aid Development Partners, there was a call that was made by the President of the United Nations General Assembly, which says that he called upon all United Nations member states, of which Uganda is, to unite at the high-level meeting, and together we can be able to end AIDS. We can end inequalities, we can end AIDS, and we can end the epidemic. Ladies and gentlemen, thank you for the opportunity to present. Thank you very much, Dr. Mubangizi, for that update. We should shortly be on our way on the final opening, but let's have a short music interlude so that we prepare. We are told that the minister, the Prime Minister, is on her way. So let's have a short music interlude, and shortly she should be here. Thank you.
Pregnant? Go for antenatal care services at a health facility. Take the HIV test with your partner. If you test positive, take ARVs to protect your baby.
Because if they take those medicines, then the baby is born HIV-free.
Join the effort to end AIDS in Uganda by 2030. Take the HIV test with your partner today.
Fellow men, support your pregnant partner to go for antenatal care services.
For advice and more information, please call our toll-free line on 0800 200 600 or 0800 100 066.
This message is brought to you by the Office of the President and the Ministry of Health.
AIDS is still with us, and Uganda has 1,000 new infections and 500 deaths every week. The estimated total number of people living with HIV is 1.4 million.
We had relaxed when it had come down, but I think we should go back. Because now we have a chance to completely defeat it. So we should talk more.
As a leader, I pledge to support the struggle against HIV/AIDS in Uganda.
I pledge support to ending HIV/AIDS by 2030.
Join the effort to end AIDS in Uganda by 2030. As a leader, play your part in the fight against HIV. For advice and more information, please call our toll-free line on 0800 200 600 or 0800 100 066.
This message is brought to you by the Office of the President and the Ministry of Health.
Did you know that 1,000 Ugandans get HIV every week? Did you know that every week 500 people die of AIDS in Uganda? HIV is still with us. In 2017, President Museveni launched the Fast Track initiative to end AIDS by 2030. We must stop HIV. The best way for young people to avoid HIV is to abstain.
Why you had to have sex at 16, at 18, at 20, and then you die or you start having problems, which you may live with all your life, why don't you wait, hold on, you study, finish your degree, and then you look for a partner at the right time.
Protect yourself. Abstain from sex until you're ready. For advice and more information, please call our toll-free line on 0800 200 600 or 0800 100 066.
This message is brought to you by the Office of the President and the Ministry of Health.
The Candlelight Memorial Day is an internationally recognized day. It is done to remember all of those people who have died because of AIDS. People who have died because of AIDS, need to be remembered so that we stand in solidarity with the ones who are left behind, their relatives, their loved ones, their employers, because of the great work they have done. So we commemorate it every 17th day of May of each year. This year, because of the multiple events happening in the country, this had to be postponed to the 27th of May. But individual institutions, commemorate this. It can be at a workplace, it can be at family level, and you do that by lighting a candle, signify, that we still remember you, we still love you for what you did, and it energizes us to continue with the fight against HIV and AIDS.
Let's light the candles and sing in harmonies to remember people who died because of HIV. Jinemi subawa, jitande konesala, yonna bigende, eribana fababazawa. Let's light the candles and sing in harmonies to remember people who died because of HIV. Jinemi subawa, jitande konesala, yonna bigende, eribana
struggling every minute to accept the truth that you have gone, staring at the children you left behind, poor kids. You left this world like rays of departing sun. Memories of your smile created big cracks in our hearts.
Let's light the candles and sing in harmonies to remember people who died because of HIV. Jinemi subawa, jitande konesala, yonna bigende, eribana fababazawa.
Stained windows sparkle as the sun is shining bright, but they end up losing beauty when the darkness falls the earth.
The bitterest tears we shed were because of losing you. You never always salute you for the endless fight you gave.
Let's light the candles and sing in harmonies to remember people who died because of HIV. Jinemi subawa, jitande konesala, yonna bigende, eribana fababazawa.
Tunajjukiranga obulamu bwe mwayitamu, tunabasabiranga kubanga mwali balwanyi. Obubaka obwaleero bwammwe abavubuka, mukole nnyo mwekuume eggwanga libeetaaga nnyo.
Let's light the candles.
I think let's take our seats. I want to take this opportunity to warmly welcome the Prime Minister, represented by the first Deputy Prime Minister, Honorable Chia Nakadama. You are warmly welcome to this function. It is a pleasure to have you. We had gone through a few presentations, and right now we want to get moving with the official opening ceremony. Let me take this opportunity to invite the Director General of Uganda AIDS Commission to make some few welcome remarks, and after that we'll invite the Honorable Minister representing the Minister for the Presidency to make his remarks. Then we shall proceed with the agenda. Thank you.
Thank you, Conference Chair. The Right Honorable Third Deputy Prime Minister, representing the Right Honorable Prime Minister of Uganda, the Minister in charge of, the Minister of State for Economic Monitoring, representing the Minister for Presidency, Her Excellency, the Ambassador of the United States of America in Uganda, Her Excellency, the Chairperson of the AIDS Development Partners Group, also UN Women Country Representative in Uganda, the Chairman, Uganda AIDS Commission, the co-chair of the conference, members of the board, colleagues, representatives of AIDS Development Partners, ladies and gentlemen. Right Honorable, you're most welcome. This is a 3-day National Scientific Conference. There is a rich menu of sharing that is going to happen during the 3 days. We've started with the opening session. Earlier on, I shared the results from the annual Joint AIDS Review the previous year. And the Right Honorable, I cannot go back, but we saw that despite the challenges of COVID, we've scored major successes, some major successes within the HIV epidemic. We've already making headway with the, we moved from 90 to now 95, 95, 95. And we are supposed to achieve these milestones by 2025. The first 95 is 95% of the people who have HIV testing and knowing they have it. We had set that target by 2025. In the first year, we are already hitting that mark. The second 95 are people who test, are positive, and started on treatment. That one, we've not yet hit it. We're at 90. Instead of 95, we think we can make it. And the third 95 is those who start on treatment can add here. We are a little far. We are at 86 out of, instead of 95. We've also identified that a lot of the factors that are holding us from achieving the targets are community factors. And that while the science and the medical professionals and public health professionals are doing their work and doing it well within the health facilities, the community component still has a lot of mileage. And we are looking to people like yourselves, the leadership. We are looking to community leaders. We are looking to cultural leaders. We are looking to artists. We've had sharing from one of our colleagues called Supercharger, an activist who has lived with HIV for more than 30 years, and so that they can package the message differently, and it reaches out to young people. So we are very pleased that you're here with us, and it is now my honor and privilege. I'm going to invite Her Excellency, the Ambassador of the United States of America, to make her remarks. And after her, the Minister will make his remarks and then invite you to officially open the event. Your Excellency.
Thank you. Excellency, if I can follow the example of my dear UN colleague, I will unmask. I'm fully vaccinated. To receive. Thank you. Right Honorable First Deputy Prime Minister, Honorable Minister of State for Economic Monitoring, colleagues, friends, all protocols observed. I'm honored to be here with you today to open the National HIV and AIDS Scientific Meeting, being held jointly with the 14th Annual Joint AIDS Review and the commemoration of Philly Lutaya. Science is at the heart of the U.S. government's health activities, and scientific innovation has brought forward numerous innovations that have evolved our collective HIV response, making it easier to reach people with the information they need to make informed decisions about their health, making it easier for patients to access the services and drugs they need, and making it easier for policymakers to understand what is needed for Uganda to achieve epidemic control. A healthy population is the foundation of a country's success, and no country can develop economically without a safe and healthy population. That is why the majority of U.S. government assistance to Uganda is dedicated to the health sector. Annually, we invest more than $500 million in Uganda's health sector, helping to address countless needs. Among those needs that the U.S. supports targets include providing life-saving antiretroviral medications and related commodities and supplies, increasing access to quality HIV services, supporting lab and data systems, strengthening community health systems for improved household health outcomes, improving the working environment for the health workforce and clients, and supporting human resources for health workers, including paying the salaries of community health workers to fill gaps at all levels. We also provide technical assistance to improve governance and leadership, to facilitate the adoption of new HIV and TB policies and guidelines based on the latest research. And we further support quality assurance and quality control and strengthening data use and operational research to inform programming. The partnership that the U.S. mission has forged with stakeholders in Uganda's health sector, to include non-governmental organizations, civil society, other donor partners, and the government, has resulted in noteworthy progress. Collectively, we have placed and retained more than 1.3 million people on antiretroviral therapy, which means Uganda is on course to achieve the 95-95-95 UNAIDS targets and sustained epidemic control. We have increased operational research to test new approaches and initiatives that have advanced HIV care and treatment in Uganda. We have empowered communities and clients to manage and monitor service provision for improved accountability. And we have strengthened civil society to provide stakeholder coordination for harmonization and efficiency in resource utilization. The U.S. government continues to work closely with the government of Uganda to progressively increase its own funding of HIV and TB service to ensure program sustainability. Efforts by the government to increase its own funding for ARVs, the number of and compensation to health workers, and to develop more innovative approaches to financing, including national health insurance and the National HIV Trust Fund, are steps in the right direction toward achieving sustainable development. The U.S. government is also committed to providing the necessary technical assistance to support the government of Uganda in building sustainable health systems and to strengthen the scientific research base to inform evidence-based policy formulation and program implementation. As a steadfast partner in the fight against HIV and now COVID-19, United States support towards HIV is aligned to both global and country-level guidelines and standards that are driven by scientific research. And as the world's leading global health development partner and largest contributor of health assistance to Uganda, United States support is improving the well-being of Ugandans of all genders, ages, and backgrounds. U.S. health programs are also fighting the spread of COVID-19 and other outbreaks of infectious diseases, improving maternal and child health, reducing TB and malaria deaths, and training local health professionals to care for their fellow Ugandans. All of this U.S. assistance is carried out through the collective efforts of several U.S. government agencies and initiatives, bringing subject matter expertise and a whole-of-government approach. They include the U.S. Centers for Disease Control and Prevention, CDC, the U.S. Departments of State and Defense, the U.S. Agency for International Development, or USAID, Peace Corps, the National Institutes of Health, which was just mentioned, the U.S. President's Malaria Initiative, the Global Health Security Agenda, and the program so essential to today's discussion, the U.S. President's Emergency Plan for AIDS Relief, or as you know, PEPFAR. And every year during the development of the PEPFAR country operational plan, the U.S. government sets aside resources to support a variety of surveys, surveillance, research, and evaluation activities. 3 examples that we are implementing with several key in-country stakeholders stand out. The Uganda Population-Based HIV/AIDS Impact Assessment, UFIA, which was already mentioned. UFIA was first completed in 2016 and is currently collating data collected this year for a 2021 update. The UFIA helps all of us to review the progress of the HIV epidemic response in the country and informs forward-looking strategies as we approach epidemic control, helping to identify population segments that are being left behind and for us to put together ambitious targets and interventions for these population groups. The HIV case surveillance of newly diagnosed people living with HIV at the time of diagnosis is another example of an activity the U.S. government is supporting to determine where new HIV infections are occurring. The availability of these data as close as possible to real time allows health officials, health projects and officials to identify clusters of new HIV infections and thus target and intensify our HIV prevention efforts. And the CRANE surveys, which are a series of surveys that look at HIV risk behaviors, prevalence, and receipt of services among key and priority populations in Uganda. In addition to national-level surveys and surveillance activities, U.S. government-supported implementing partners continue to lead on operations research and implementation science with the support of the Ministry of Health and the Ministry of Gender, Labor, and Social Development. And over the next 3 days, we'll see and hear from several of our partners here in Uganda as they share scientific lessons and findings along the HIV cascade and continuum of care. So as I conclude, I want to reemphasize that the U.S. government has been and remains a strong partner in improving health and preventing outbreaks in Uganda. There have been significant strides made in Uganda in the fight against HIV, and building on this, the U.S. government supports leveraging critical scientific advances in HIV prevention, diagnosis, and treatment in order for us to reach the last mile, targeting those who remain marginalized and excluded. We also remain committed to the simultaneous battle against COVID-19. The United States donation of more than 5.8 million COVID-19 vaccine doses to date, so with more on the way, continues our decades-long investment in Uganda's health sector and in the health of the Ugandan people. In addition, we've provided significant resources to help distribute these vaccines throughout all parts of the country and to support the public health workers in their work to help the infected. So whenever I have a platform like this to address the Ugandan public, I encourage everyone to help fight the pandemic by getting vaccinated and by encouraging all of your friends and families and co-workers to do the same. We know the vaccines are safe, we know they save lives, so please get the jab. So Ugandans can count on the United States to support their efforts to fight the pandemic, to get the economy back on track, and to reopen schools. Together, we've worked to bring the HIV/AIDS pandemic under control. Together, we are working to combat malaria and TB. Together, we are improving child and maternal health. And the United States will stand together with the Ugandan people until the COVID-19 pandemic ends. And thanks to our strong investment and strong partnership in health, millions of Ugandans are living healthy, learning better, earning more, and participating more fully in their communities. And we look forward to building on these successes. Thank you.
The third, Right Honourable Deputy Prime Minister and Minister without portfolio, Her Excellency the U.S. Ambassador to Uganda, Her Excellency the Chairperson of the Development Partners present here, the UN Women Country Representative present, the Acting UN AIDS Country Representative, our keynote speakers, Development Partners, the Chairperson Uganda AIDS Commission, and the board, our online participants, both local and international, all our stakeholders in the fight against HIV/AIDS, the media, ladies and gentlemen. My name is Peter Ogwang. I'm the Minister of State, Office of the President, Economic Monitoring. On behalf of the Presidency, I welcome you all to this important national scientific meeting that is also featuring the 14th Annual Joint AIDS Review and Philip Lutaya Memorial Lecture. I would like to thank the Uganda AIDS Commission and the Uganda National Academy of Science for spearheading the preparation for this event. My appreciation goes to all of you, the stakeholders, for your continued collaboration in the national response of HIV/AIDS. As most of you may be aware, in 2017, the President launched the Presidential Fast Track Initiative to end AIDS as a public health threat in Uganda by 2030. The objectives of the initiative include engaging men in HIV/AIDS prevention to close the tap on the new infection, particularly among the adolescent girls and young women. 2, accelerating the implementation of test and treat and attainment of the fast track 90-90 targets, particularly among men and young people. 3, consolidating the progress on the elimination of mother-to-child transmission of HIV/AIDS. 4, ensuring financial sustainability for HIV/AIDS and AIDS response, and ensuring institutional effectiveness for a well-coordinated multi-sectoral response to HIV/AIDS. This meeting over the next 3 days is going to bring to us all together researchers, policymakers, service development implementers, people living with HIV/AIDS, development partners, and communities to share new knowledge on HIV/AIDS epidemic and to reflect on the implementation of the presidential initiative. The various research findings that are going to be disseminated by the different stakeholders should give us a good evidence-based picture of our collective efforts and what needs to be done. This will be the time of reflection during the Joint AIDS Review. We should use this time to listen and check whether we are on track regarding those 5 objectives. Are the targets that we are set as a country in the National HIV/AIDS Strategic Plan in sight? I thank you for selecting a very relevant theme, HIV, AIDS, HIV, and COVID. Reflecting on our vulnerability and resilience, this morning we have been reminded about the strides that we have made in fighting the HIV/AIDS epidemic. We have also seen and we know that COVID-19 set in and has disrupted a lot of the gains that we had made. As we reflect, it's important to ensure that each and every one of us should make individual accountability. For example, how are we taking personal responsibility to prevent new HIV infections? How do I protect my family, my neighbor, community, and the country at large? Have you taken the HIV/AIDS test? Have you been encouraged? Have you encouraged your family and those around you to take the HIV/AIDS test and know their status? Government has made available the HIV testing services in various health facilities, and I encourage you to utilize these services. When it comes to care and treatment of those living with HIV/AIDS, government has invested a lot of resources in ensuring that people can access treatment at health center 3s. I would like to thank our development partners who continue to give government a hand in availing services to the people. Thank you all partners for the support you're giving to the people of Uganda. As government, we have already heard about the 90% of the people living with HIV/AIDS in Uganda are able to access treatment services. This is a key focus on the presidential initiative to end AIDS, and I thank you all for heeding to the call. When it comes to ensuring institutional effectiveness for the multi-sectoral response, government has invested in this as well. The Office of the President, where I am, and of course my senior is in charge, provides oversight through the Uganda AIDS Commission for coordination of HIV/AIDS and services in the whole country. I receive reports on a monthly basis about HIV and AIDS activities, and I'm able to provide updates to HE, the President. Our chief guest, on the 3 days of our program, we shall be commemorating the Philip Lutaya Memorial. As many of you know, Philip Lutaya was the first Ugandan to openly come out and declare his positive status, and I think we need to clap for him as a country and as development partner. He was a celebrity in the music industry, but that did not hinder him from coming out openly at a time when HIV/AIDS was viewed with a lot of stigma. It is therefore befitting that we celebrate this legend for his historic act that consequently contributed to the fight against stigma and discrimination of people living with HIV/AIDS. As I conclude, let me once again thank all of you for committing your time, energy, and other resources to participate in this national scientific meeting. As Office of the President, we are keen to receive information from this meeting that we shall utilize as we plan and take decision towards the efforts to end AIDS as a public health threat in Uganda. Right Honorable Prime Minister, before I end and invite you here, allow me make one or two things. Number one, on the special note, as the Minister for Presidency, I would like to begin by thanking the U.S. government and the development partners who have continued to help our country. I think we need to clap for them in a very sincere note. As Presidency, we really commend. More so, like Our Excellency has just mentioned, the support they have given us on the fight against COVID is very, very commendable. We want really to thank you on behalf of the government of Uganda. Number two, Right Honorable Prime Minister, there has been a question here which has been given to us. Government should help in providing the people living with HIV/AIDS, about 1.5 million. What plan do we have for them in the budget? I am happy we're in the budget cycle. I am happy Uganda AIDS Commission is under our presidency. It's important I invite you to come up with strategies and plans on how, as government, we can see how to begin helping those people directly as a government of the Republic of Uganda. That I take it on behalf of my senior minister. Last but not least is to ask all Ugandans, so if you know you have not got your jab, you have not taken your vaccine, please. It's important that we go out there. That's why I've thanked the development partners. Gone are the days when we used to complain there were no jobs. Today, everywhere you go in the countryside, there are jobs. So when we're talking about COVID, can we help ourselves, mobilize our people, our communities to go and vaccinate? It's now my honor and privilege to invite the third Deputy Prime Minister to come, make her remarks, and officially declare the National Scientific Conference open. I thank you so much for listening to me. Thank you so much.
Thank you so much, Honorable Minister. The Minister representing the Minister for the Presidency, Honorable Peter Ogwang, Your Excellency, the East Ambassador, Natalie Brown, Honorable Members of Parliament, I guess there are some present here, UN Resident Coordinator, Your Excellency Susan Ngonji, Chairpersons, the Chairpersons of AIDS Commission, the development partners, friends, ladies and gentlemen. I'm called Nakadama Rukia Isanga. I'm the third Deputy Prime Minister and Minister without portfolio, again in the Office of the President. So I have, my legs are like this. I'm in the other side of the Prime Minister and also the other side of the Office of the President. So I'll say good afternoon. Yeah, good afternoon. before I begin, I will say we are sorry that this morning it has not been all that good because of what has happened in town. We've heard that some of our people have died and some have been injured. So security is it is in charge. We just pray for those whose lives have gone, and we pray for those who have been injured, quick recovery. But let's hope everything will be settled. I'm happy to join you today for this National HIV and AIDS Scientific Meeting that is also featuring the great works of our heroes like Phile Bongoli Lutaya, the man who contributed a lot in fighting stigma against people living with HIV/AIDS. I thank the organizers, particularly Uganda AIDS Commission, and our partners for putting together this event with an important and timely theme of HIV and COVID-19, reflecting our vulnerabilities and resiliency. For society to transform, research, innovation are vital. As NRM government, we have prioritized scientific research to inform our decision making. His Excellency, the President of the Republic of Uganda, Yoweri Kaguta Museveni, as you are aware, is a strong supporter of science, and it is for this reason that he has directed that the priority of government should be to support science, to research, innovate, and find solutions to the challenges of our country which is facing. I therefore would like to call upon our sons to come up with more innovations and researches that help address the key challenges facing the country in areas of health. I would like to salute our sons who continue to make us proud. For example, I'm told that Ugandan sons at Makerere University were the pioneers who discovered the antiretroviral therapy for the elimination of mother-to-child transmission. We now challenge you to discover the medicine for the cure. We need to clap for them. We want to see you come out with research that addresses the practical need of our women, children, and men, not the abstract ones that remain on paper. Friends, I'm pleased to learn that the studies and research that will be shared during this conference are focused on the real issues affecting our people. Uganda sons can count on the NRM government support in their endeavor of ensuring that research is translated into action. Already government has provided scientific support to sciences in various innovations and researchers. For example, COVIDX for managing COVID-19. As the country moves towards the ambitious target of ending HIV and AIDS in Uganda by 2030, His Excellency the President launched a drive in June 2019 called the Presidential Fast Track Objectives, with the aim of prioritizing, testing, and treating, and the eliminations of mother-to-child transmission of HIV/AIDS, so that we achieve zero new infections among the new child born in the country. I think this is a program that has been moving on, and I implore you people to come up with the statistics of the children who have been born without HIV/AIDS, with those people who are positive. I've seen many people have gone on to conceive yet they are HIV positive, and as if the number has really gone low. So it is better if we come up with the statistics of what is happening in that area. We have made good progress in combating the HIV and AIDS epidemic with reduction in the new infections, HIV prevalence, and AIDS-related mortality over the past 10 years. Uganda is one of the 14 countries globally that achieved the 90-90-90 target by 2020, ensuring that 90% of the people living with HIV/AIDS are aware of the HIV positive status. 90% of those tests HIV positive are on treatment, and 90% of those are virally suppressed. I think that is a very big achievement. I thank all those who have contributed to these results. Just like His Excellency the President is providing wise and strategic leadership in the fight against the COVID-19 pandemic. The President, as you know, was the vision bearer in the fight against HIV/AIDS from the earliest days. He led from the front, creating awareness about the dangers of the disease and warning Ugandans to be careful with their lives. He rallied all the stakeholders and created maximum advocacy to improve the HIV awareness among the communities in Uganda, which worked up to date. It worked up to date. I hope people still remember really how he has fought, how he has mobilized people, how he has, given us support in seeing that our people really can, they should be caring about their lives so that they are not infected with HIV/AIDS. Following his HE, the President's exemplary leadership, many prominent personalities, like we have said, Philebongo Lutaya, came out to fight the stigma and discrimination among people living with HIV/AIDS. As we root for the free stigma-free environment, I therefore call upon our people to emulate such personalities and speak boldly against stigma and discrimination. Recently, I had somebody who came to visit me at home among my voters, and then he was telling me, Honorable, I'm HIV positive. But he had just married. He had come for support because he had a wife who was expecting. So he wanted to get some support so that the wife cannot reach that time of delivering when you don't have the money. So I was asking him, why did you get married if you knew you were HIV positive? So he narrated the story. But it was, I think, that time when people could not talk about such things. Nobody could come to you and, telling you, I'm HIV positive. It was not there. So I think we need to call upon people to continue coming up with such messages, fight the stigma, so that, we get more and more to know their status and they can talk about it. I, however, have noted that despite the success registered, the burden of HIV remains, with HIV prevalence being higher among women at 6.8% than men at 4.2%. Amongst older adolescents and young people, prevalence is almost 4 times higher among female than male. So I think we need a lot of sensitization in this area. What can we do for them? We need to talk to them. We need to sensitize them. They should be aware of what is going on. And I challenge all stakeholders present here that we need to fight this challenge together and ensure appropriate messages reach the community to reduce the HIV infections among the population. As part of the policy shift, the government has now embarked on implementing the parish development model as a way of delivering services to the last person in the village. We believe that through this approach, even services to people living with HIV/AIDS will be reached easily through this model. In fact, when we were planning, people started bringing out issues like, how can we reach people with HIV/AIDS? How will they get this service? Will they be allowed? But because now the discrimination is not so much, some people, of course, come out and say, we have people living with HIV/AIDS, let us give them their share. So they can go with that. So as I conclude, I'm stating that the NRM government will continue supporting all the initiatives aimed at ending HIV and AIDS across the country. Thank you. And the plan for the people, like the Honorable Minister raised, how can we come up with a plan to see that these people should also be put in the budget? I think all those will be worked on since we are in the, this is budget time to program, to see what are the priority areas, where can we put what. I think we need to come up with something, with your help, you people who are here, to tell us exactly what we can do so that we can enrich our budget with also the support for people living with HIV/AIDS. With those few remarks, it is now my pleasure to open this National and AIDS Scientific Meeting, officially opened. For God and my country, I thank you.
Thank you very much, Third Deputy Prime Minister. We do appreciate, we don't take it for granted coming to join us on a day like today. So we are really grateful, Honorable Minister, Economic Monitoring. It has always been a pleasure to interact with you. Your Excellency, thank you very much for joining us today. And similarly, the chairperson of the AIDS Development Partner. Thank you for all your remarks. We are going to have a group photo which is restricted because of the size of the space that we have. So I would like to invite the chairperson, Uganda AIDS Commission, and the Director General, Uganda AIDS Commission, to come up front here and join the high table, and we take a group photo. After that, we shall be proceeding for lunch. Make sure you keep your bag close to you. Now that the Prime Minister has mentioned it, we don't want your bag to be far away from where you are. If it is far away, we shall get concerned and find out why. So let's move down here.
Ladies and gentlemen, we want to thank you for your participation this morning, and we will now break for lunch. I hope each of us has received a lunch coupon. Lunch will be served by the swimming pool. I think that dining area is called the Arches. And we shall take a lunch break of 30 minutes. Like you've heard, we would not like to stay here till late. So it is in our interest that we take a shorter lunch break. And when we return after lunch, we'll be breaking out. As you could have known, we will have 4 tracks. And we will go into different rooms. These rooms have already been labeled, but just to simplify everything, we will have track 1 on epidemiology. Dr. Zephyr wants you people to laugh at me, but that one.
It's epidemiology and
prevention.
HIV prevention.
Yes. That the people that will be participating in that particular track, this will be your room this afternoon. It is the Nile Hall.
And then track 2, that is basic science, care and treatments. You go to Orange Hall, which is lower floor, yes, the down floor.
Then track 3, social support, human rights and gender, we shall be in the Rees Hall.
Track 4, system strengthening and strategic information, we'll go to Mayanja. Mayanja is next to the swimming pool, I think on the right. Just to remind ourselves, we have exhibitions down there, downstairs. We can take off some time and go and check out on these amazing exhibitions from different CSOs. Thank you so much for participating in the morning session, and we are looking forward to the afternoon. If you didn't get a coupon, please feel free to reach out to us. You'll get one. Thank you.
For our online audience, there are breakout rooms that we have organized. Like I've been mentioning, there are 4 separate breakout rooms. So below your screen on the Zoom taskbar, you will see the different breakout rooms. There's HIV prevention, and then we have system strengthening, then social support, and then care and treatment. So you have an option of selecting which breakout room that you desire to go to, and once you select the room, you'll be directed to that particular room, and then you'll be able to attend the different presentations that will be taking place in those particular rooms. You'll be able to use the same link that you used to join the meeting to be able to access those breakout rooms. Thank you.
Okay, bon appetit.
Nice lunch.
sure it's nice. A nice one. They don't know how to smile. So make sure the wife, you know how you're going to do it. Making sure it's just nice, that is all. Now we'll cook over you. Talk be on a wali. We male. You put there bulungi. Now jam cook over for your bed. Okay. Okay. Professor, you're going, you're not coming back. Toy Jacqueline. For you. Okay. Smiling. But now you're trying to be chinning and get you. As long as chivayo chimu nga chinyumi olide bayo chimwe nga chiri mwa eh Omaze leta tula
kaza kabari university yekonka twokubona twamunigirayo utakaza yakukuba nabona vice chancellor wa kusitema nagira ngo chance yo kumutwara kusitema zizima because they had 1,000 applications and they only selected 40. So clearly appoints zeye yagira ngo chances ziriho even na solution ayo tuzi so umwanya gwo kugira ngo haferwe medicine kandi na care ibisete ziri nyinshi munonga itwara buku twamunyigira twamunyika akaza kabari Good afternoon, Jen. How are you? Hey, how are you? Nice to see you. I'm okay. How are you doing? I'm okay. How is management? It's fine. Okay. It's fine also.
Okay, this is okay. Oh, so you use this. Oh, I can't move this, I think.
You were tired of being the woman at home.
Be running to go back because I don't know what's happening on the computer. What? She's there. So I can cover them. Sit down and
you relax and you know. Okay.
But she will continue supporting that project because they have started so many other things, things, research, but I'm not no idea.
And that's what I want to learn, how to do operational research within these programs without stepping on the toes of technical people.
It is named the USID that you can do that. CBC, but USID you can do because USID, and even those small grants, they are USID funded.
They are still USID funded. Yeah.
Yeah, because USID has always those small grants they look at.
And those are the ones I want, even any research, whoever, doesn't matter, as long as USID can allow me to work within their things.
Yeah, they always ask for you to do some operational proposal. And then the problem is they want to look at response among caterpillars that go to the borders and then they will support.
Okay.
Yeah. I wish you were really, it's a very virgin area.
Difficult. Really very difficult.
Yeah. So you have to rely so much on the community component.
A lot of it. Yeah, a lot of it. I saw, I was in there last week and I was looking for her to see how they are doing the community component of TV, how what we can learn from
Just
there.
get her, organize a meeting and talk to her. It's better even if it is in-house. Because there are some people in USID very soon born. Yeah, so I think we just need to have an in-house meeting and talk. There are some innovations which are done which actually plant
Talk on TV. But I mean,
now you're in plant.
officially. No, we've started already. We've already started.
Okay, 0722.
Until she went there, she was exposed.
Yes, no, even when she went like the TV program was doing so badly in West Nile. And she changed it.
Okay.
And now they started with fun.
Okay.
And when she left West Nile, CBC did not
You were
like
not
it.
happy.
Yes. So up to now, CBC still goes up West Nile.
Oh, really?
Yes.
On IDI is still on.
On IDI, they follow her. They made it that she stays 10%.
Okay.
So she has been there. Now I think the problem is urban TV. That's why she's
She was working with Goma on the TV program.
differ, but when you have your assumption right, but the problem is to differ when actually you can't.
But if the findings are there,
That is because if in the community sometimes maybe lower, I mean higher than 100%, then you know the facility is supposed to be a bit something has to be logical, which side is fine. There's skew so much, then and there are many people with interest, so
everyone,
you can't just put it there.
You can't just put it without saying that everyone has interest.
It is. Actually, surprised.
Testing and viral load and all those things.
This one I'm surprised. This was from the last time, remember, they completed it. Got results in 2017. Yes.
Final report.
It was 2016. Well, they we had some.
By UNICEF, but in Newport. But the health aspect of Newport.
We'll start. The people are in your
Yeah.
You need to see who the other presenters are.
Hello.
Good afternoon. Talk to that guy for me. Yeah.
Online, there are 4 people.
Well, there are 4 people online. So what is he waiting for? 'Cause it is already 3. So you're now the director of the program? Exactly. Mm. I think those guys are not switched it on. Good afternoon, good afternoon. Good afternoon, ladies and gentlemen. We need to start this session, and I want to thank the people who are already online. I'm told there are people online. I want to thank you for your patience. We are starting this session a little behind time. The session is on epidemiology and HIV prevention, and specifically we shall be focusing on HIV among children, adolescents, and young people. My name is Dr. Tindiebwa. I'll be co-chair this afternoon for this session. I'm still waiting for my co-chair, Dr. Conrad Muzora. And I wanted to start by taking a roll call of the presenters. I have seen Dr. Jenny Nakawesi here. I've seen Agnes Nyapio. And can I, by raise of hand, can I see Elizabeth Kemigisha? Or if you are online, you let us know.
I'm online.
Ahabwe Johnson, if you're online, you let us know. Ahabwe Johnson, you're there? Great, thank you. And Agava Mark, excellent. So we have all the presenters except Elizabeth, and that means that we are good to go. Because of what happened this morning, we should get out of this place as soon as possible. I'm sure there's going to be a big rush out of town after 4, so we shouldn't reach 4 o'clock. And on that note, can I request the presenters to be as brief as possible? I don't remember what time you were given, probably 10 minutes, but see whether you can do it in 8 minutes. And once again, you are welcome. Because I don't see Elizabeth Kemigisha, I will now ask Dr. Jenny Nakawesi to make her presentation on characteristics of children newly diagnosed with HIV in rural Uganda. Dr. Nakawesi is a pediatrician, and she's the senior technical program manager, MARDME. Welcome, Jen.
Thank you. Thank you very much, Dr. Tindiewa, and good afternoon to you, ladies and gentlemen. I'll go straight to my presentation. I requested that I present from down here. I wanted to use the bigger screen. So, yes, are we ready? Oh, yes. Yeah, like Dr. Tindiewa rightly introduced me, I work with MARDME Uganda. Next slide. Oh, should I use it? Okay, so by way of background, we know that globally about 1.8 million children are living with HIV, and that was by 2019, and this was obtained from the UNAIDS 2020 report. By then, only 53% of children living with HIV had accessed treatment versus 68% for adults. This is globally. Then in Uganda, about 98,000 children are estimated to be living with HIV. We know that of those, about 60,000 have been diagnosed and are on treatment, but a few more are yet to be identified. We also know, however, that new HIV infections among children have declined by about 52% in Uganda since 2010. And identifying the remaining undiagnosed children is quite difficult because there are very few. Most of the children, if you test them, are negative. And we know that we have to do targeted testing for cost effectiveness. So we undertook this to describe the characteristics of newly diagnosed children in 8 districts of rural Uganda. So we did a chart review of children under 15 newly diagnosed with HIV during the period from October 2019 to January 2020 in Mubende region of Uganda. This Mubende region constitutes 8 districts of Mubende Mtyana, Chiwoga Chankwanzi, Luwero, Nakaseke, Nakasongola, and Kasanda. So data on social demographic and clinical history was collected using a data abstraction tool. We did descriptive analysis, descriptive analysis to examine the distribution of variables, and this analysis was done in Stata 15. This work was approved by Mayume Uganda Research Ethics Committee under the Mbende Region Protocol and registered with the Uganda National Council of Science and Technology. CDC approval was also obtained. Okay, so by district, majority of the children were identified from Luwero, the total number being 125 in that period under 15 years of age. And the other districts, as you can see, there are a few, four were from the districts outside the region, and those were referrals in to the region at the time. The median age was about 3 years, with an interquartile range of 1.25 to 8 years. Okay, so by sex, it was 50%. Sorry, I don't know what happened there, but 50% were female, 50% were male. Something seems to have happened to the slides, I don't know. Okay. By testing modality, 58% were identified through index testing, where index testing is testing of the biological children of index clients, those clients, adults who have been diagnosed with HIV. And the other bigger portion, 22%, were through the early infant diagnosis. Another bigger lot was from OPD, and then the others, as you can see there. So over 80% were diagnosed in essence through index client testing, because even those from EID are usually from the HIV positive mothers. Only a few of them though, 14% were in WHO stage 3 and 4. So with advanced disease in essence, so majority of those diagnosed children were well, they were in stage 1 and 2. The stage 4 conditions are not included here, but they included TB, persistent diarrhea, one had cryptococcal meningitis. So among the caregivers, 77 of the 125 had biological mothers as their caregivers, and of those caregivers, 60 of the 77 had not received PMTCT services. And from the EID testing mortality, 89% of the caregivers were mothers in HIV care, but 56% of those were virally non-suppressed. Only 44% of the children diagnosed through EID had been attended to by a skilled birth attendant, or a skilled health worker. So that means we had majority being either delivering from home or from a TBA. So in conclusion, testing children exposed to HIV through index testing and prioritizing children of virally unsuppressed mothers could increase case detection rates among children. Increasing access to PMTCT services and skilled birth attendants are urgently needed to achieve pediatric epidemic control. I'd like to acknowledge the children and their caregivers, the supported health facilities and districts, and the project team, and the donor for the funds that we utilize to do this work. Thank you very much.
Thank you, Dr. Jenny Nakawesi. We now move on to the next presenter, who is Ahabwe Johnson. He's going to talk to us about the use of films to reach more young people to reduce HIV and AIDS infections, end AIDS by 2031. Ahabwe is the director, African Youth with the Light of Peace. Johnson Ahabwe, please go ahead.
Good afternoon, members. My name is Ahabwe Johnson, as well said. I'm presenting on the use of films to prevent young people from contracting HIV. As I'm waiting to see the slides on the screen, yes, that's it. We are shooting in the target to end HIV by 2030. Next slide. African Youth is a youth-based organization that was registered in 2016, and it is based in Mbarara, but nowadays establishing in Kampala. It is targeting to empower young people in areas of socio-economic development and health education, specifically on sexual reproductive health and rights. Next slide. Slides are a little bit slower than the time. Oh, okay then. Thank you. ILAP really works in the communities where young people can be identified, specifically to capture their ideas and views. We realize that if you are to program for young people, you have to know what they do, what they want. As we all know, HIV prevalence among young people, more especially children, is at 0.5%. Then 7.6 among adolescent girls, then 4.7 among young boys. This is a big percentage of young people, and we thought of a situation that if we attain the 2030 target, we have to contain this situation, basically through prevention. What we do basically to do this, we produce films, prevention and awareness films, with specifically a feeding behavior impact, FBI. What is it? It is when you are producing a video that shows the alternative way of the behaviors we usually talk about, the risky sexual behaviors. Yes, we have seen a lot of videos, but did they have this content? And if you are providing educative video, we thought it should have the other way, which is not the risky one, so that a young person can make an informed decision. Then after doing those videos, we produce CDs and distribute them to schools as one way of distributing those videos and films. And we also document the lessons learned. We visit schools to capture what young people learned from those videos. And we do that by conducting school health outreaches, basically to know more if our videos are doing the right job we produce them for. We furthermore upload those videos to different social media platforms to encounter bad content on social media, where young people usually be. When we get opportunity, we do report the achievements to the stakeholders and partners. Finally, we do the research bit of it, more especially on what young people really like. Briefly, these are young people watching some of the videos we produce in schools, and you can as well see how young people can pay attention to those videos. And we thought of videos can be one way great channel where you can capture the attention of young people. This is another school, young people enjoying the video as they learn, at the extent even they take notes. They learn the video, they learn what we do as they enjoy. These pictures are just to prove that young people can really watch those content once they are produced properly. They give all it heartedly and sacrifice time. These are young people out of school. Whereas we target in school, but as well we can as well capture out of school because of the same age bracket. These are the young people out of school. What were results? One result is that one of the films we produced was cleared by Uganda AIDS Commission, which we're really happy of, because it is hard also to produce a content as well as to be cleared. We are happy for that. Second, ILAP has reached 1,137 young people in schools. The other outreaches are showed, and 700 on our YouTube channels with the prevention messages. ILAP has documented lessons learned by young people through watching these films we do produce. Acquired partnership with schools, because we engage young people to act these films and really come up with the content they want to really bring out, what they feel. So to get those people, we go to schools so that we can work with young people, both in production and watching those films. We have mastered the art of involving young people in production of these films, whereby young people write and act these films. For us, we just provide technical assistance. We want to capture the peer-to-peer influence and really bring out the impact of how a peer influence can change a person of the same age. Well, ILAP has produced 10 short movies on prevention and awareness since 2018. We have really put much emphasis in this area. Could I say that we are many controllers? I'm the one. Is anybody I'm controlling with? Sorry for that glitch. Sorry. No, it's not done. Okay. I will use small technology. as we move fast to finalize that. As we saw young people watching videos, we wanted to capture if these videos can really do the work we intend to do. And here we are saying why films? Basically, a film brings real life picture that creates everlasting memories in the brains of young people. That is where our business is, because we need to create like vivid evidence in young people's mind to keep reminding that this is bad, this is good, so that we help young people make informed decisions about their lives. Films are easy to disseminate across multiple media platforms, and they bring details when they are produced to a final product. So they can easily go even if we are in the area like this, where we have COVID-19 pandemic, videos can keep moving. We are not shut off. So young people like films because they are easy to digest. It is not hectic to really understand the content. It is self-explanatory to young people. They watch and learn. So that's why we think investing in films is very paramount. And we see many value chains in video, right away from production to final product. Even young people, when they are writing the script, they are learning. Even the people on camera, they are learning. Even the editors, they are learning. So actors themselves, they are learning. Distributors, they are learning. So you end up with a lot of value chains in video production and dissemination. And they also improve skills. A young person can learn writing, can learn acting, self-esteem, decision-making. All those are important lessons that one can have or learn like in this life. Main objective of the project. This main objective of Film Ending AIDS project is to reach out to 10 million young people. We are targeting 10 million young people in primary, secondary, and out of school, but of the same age group, that is from age 8 to 24, with prevention and awareness messages. How are we intending to do this? From 2022 to 2026, we are targeting to produce 50 short HIV prevention awareness films for both sections, upper primary and secondary. We are also intending to disseminate these films in primary and secondary schools. Other partners, we are to conduct LSA outreach to reinforce the messages. Dissemination of films may not be on enough, but we need that person to capture what young people have learned and to share and interact for more learning purposes. We intend to upload these videos on different social platforms and organize national meetings to report the progress on the project. A meeting like this to make a report what has been achieved is also paramount in prevention. Can I have another slide? Where is our strength to do this? Passion. We are passionate about this specifically. It's our main strength. Commitment. For over 8 years, we've been really doing a research how to do this come out perfectly. We have reached about a level to do a perfect feeling behavior impact film. That it is a real learning tool for young people. It's another one of our strengths. Teamwork. We don't do these films alone. We inquire from people, information, partnership. With such a presentation, we expect partnership from you people because it's a great work. Film content is really involving education system. We are looking at ourselves not to really hustle much to go to schools. We produce CDs. Education system is willing to really support us in dissemination of these CDs. We are also having high levels of professionalism. Just focus on what we're doing. It's another strength we got. Strong bond and good working relation with students. For this period we have worked on these videos, we have really developed a strong bond with young people to understand what they do, what they think, how they communicate. So we understand their language through activities we usually do. like in that picture, we are distributing to them educational materials, but basically on healthy, on living a healthy life and a happy life, both in secondary schools. So you can see those are primary students. That is I myself in green, reaching to young people, teaching them climate smart agriculture, socio-economic development. That is our admin supervising the activity. These are young people who gather to watch these films. They really enjoy. What do we expect? We expect to reduce 3% out of 12.8. When you add the HIV prevalence among young people, children, and adolescents, you get to 12%, which is a big number. We are looking at to reduce at least 3% by 2030. How? By reducing new infections. Of course, these young people like acquire HIV when they indulge in risky behavior sexually. So at that stage, they really acquire HIV, and we are targeting that area, new infections for young people and adolescents. What do we come up with to say to a certain platform? HIV AIDS awareness films should be adopted because young people like these films. School outreaches, it is not only teacher to teach everything to the students. People can come on the school from outside, and they really deliver a very strong message that really remain in the minds of these young people. One of AIDS and educative film to be disseminated. We cannot produce them, then they keep on our flash. It is very terrible. Much emphasis should be put in prevention as it is put in treatment as of now, because we are targeting to close the other first door. Finally, but not final, we can't express enough thanks to African Youth with the Light of Peace, patrons, well-wishers, for their continued support and hard work towards the success. This innovation may look small, but it really engaged a lot, time, resources, research, and the team was there for sure. Finally, I express my special thanks and gratitude to the Uganda AIDS Commission and partners that gave me this golden opportunity to make this presentation. If it was not them, then we couldn't make it here, even to show what we do. So thank you, members. It was a little bit longer, but it intended to be shorter. Thank you. I look forward to work with you. The innovation is still open for partners and fun. And finally, Director General, Uganda AIDS Commission, you are the one we have here in this room. ILAP is here. We can work with you under you because we don't intend to create another program or agency, but we look to see existing commission which understands what the work we do so that we can do better. Thank you.
Thank you, the African Youth with the Light of Peace, for those messages about the use of films. Told we have between 20 to 25 participants online, which is very good. Please, if you have any questions, write it in the chat box, and then at the end we will receive those questions and ask the presenters to answer. So we have had now 2 presentations. If you have the questions, please write them in the chat, and then we will pick them and give it to the authors of the papers that have been presented. So while we wait for that, I'm glad to say that Elizabeth Kemgisha is online now, and she's ready to present. She's going to talk about, to give us a paper on qualitative study on attitudes, perceptions, and experiences on sexuality education in schools and communities in Uganda. Elizabeth, you are welcome. Please go ahead.
Thank you so much for giving me this opportunity to present this study. This study is a UNESCO-supported study that is being conducted in 5 other countries, including Ghana, Zimbabwe, Eswatini, Botswana, and Malawi. So I will be presenting the findings for Uganda. So I'm presenting a qualitative study on attitudes, perceptions, and experiences regarding sexuality education in schools and communities in Uganda. And I'm a pediatrician and a lecturer at Mbarara University of Science and Technology. I acknowledge the funders, UNESCO, GMAT consultants, and the support we have received from the Ministry of Education in conducting this study. Next slide, please. The previous presenters have given a background on HIV prevalence among young people, so for purposes of time, I did not include that. So I'll give a background related to sexuality education in Uganda. Sexuality education is part of the school health programs that have been ongoing since the 1980s. But here I present the program that have had a large impact. For instance, in 2003, the president initiated what is commonly known as the Presidential Initiative on the AIDS Strategy for Communication to Youth, an AIDS program that was targeting young people by sensitizing them about HIV prevention. Despite the successes of this program, the PSC had challenges in its coverage on the sexuality education content because their main focus was HIV prevention. Along the years, in 2013, 21 Eastern and Southern African countries endorsed and affirmed their commitment to ensure better health outcomes for adolescents and young people in a way of promoting sexuality education as well as access to sexual and reproductive health services. Central to these ISA commitments was the agreement to scale up sexuality education and access to services for adolescents and young people. At the end of 2018, 14 of the 21 ISA commitment countries were offering SE in schools, and 17 had SE strategies for out-of-school youth. And in 2018, in accordance with the ISA agreement and to complement ongoing efforts on SRH information for learners, the Ministry of Health published the National Sexuality Education Framework. Several other policies from the Ministry of Education and the Ministry of Health support provision of information and services to young people. Among these include the adolescent health policy and other policies that most of us are aware of. So this is a picture of what we call the talking compounds, which is one of the components of the PSA program. We can see delaying sex and emphasizing virginity. Next slide, please. So sexuality education, by definition, from the National Sexuality Education Framework, refers to a lifelong process of acquiring and learning and teaching acceptable information that is age appropriate and religiously appropriate. It aims to address the social, cultural, the spiritual dimensions of sexuality regarding feelings, values, and attitudes, and developing communication and decision-making skills. So it's all encompassing and not necessarily talking about sex. Thank you. Next slide. So the objectives of this research study were several, including understanding the attitudes and perceptions of learners and teachers and community members regarding sexuality education, and understanding the factors that influence the delivery of sexuality education, and also examine linkages between sexuality education in schools and how this can promote uptake of sexual and reproductive health services in health facilities. Next slide, please. So this was a purely qualitative study, and our target population were key informants from the Ministry of Education, teachers, learners, school administrators, and community members, and these were several, including parents, social workers, the police, religious leaders, and health workers within the catchment areas of the schools which were included in this study. Next slide. So I'll go to the findings. So the participants, I've already mentioned who they are. I would, for the Ministry of Education, we looked at the National Curriculum Development Center, the examination body, departments of gender and HIV prevention, and then Ministry of Health, the Adolescent Health Division, and the schools were selected mainly from the western part of Uganda. This was a complicated study that was conducted in the middle, just before the proper opening up, that was in September 2020. So it was not easy for us to reach out to other communities. So we could only do it in the location where the consultant was. Next. So we had also focus group discussions among learners in different categories, including, please, keep pressing, learners, females and males, and also mixed groups. And then we also had teachers. We also had a focus group among the parent teachers associations, and also focus groups among the parents themselves. Please continue on the slideshow. Yeah, thank you. Next slide, please. So regarding the attitudes and perceptions, the first group we looked at are the learners, and the learners were categorized as learners without disability and those with disability. So among learners without disability, they had positive attitudes towards learning topics related to sexuality education due to the perceived benefits and relevance to their stages of growth. Among these benefits was acquired knowledge on prevention of HIV and teenage pregnancy, hygiene habits, developing self-confidence, and handling peer relations. Please press the slide. So one of the quotes here says, I was also impressed by the sexuality education topic on human body development, because when you start menstruation periods, you start growing pubic hair and start developing breasts. It is normal, so we should not get scared because we are undergoing growth. And this was a female from a primary school. Next, please. However, there were some challenges. Learners felt that teachers are shy or embarrassed to talk about some topics related to sexuality education. They end up using terms that are related to the actual name. They cannot say sperm, they would rather use another term because of the cultural values and attachment to the topics. And because they are shy or not confident enough, they tended to rush through the content. That's what the learners felt. And also the learners felt that these lessons were not taken very seriously because some of the content in these lessons was not examinable. Next. So among the teachers, they think sexuality education is important in shaping learners' behavior and addressing their pubertal challenges, but as also from the teachers themselves, they said they felt embarrassed and uncomfortable in discussing certain sexuality topics due to their personal values, norms, or cultures. And we have a quote below. Please, the slide controller, yes. The topic on body changes disturbs me a lot. because when you say something like pubic hair, the students' attention all goes and they start laughing. So in the process, time is lost for you to explain well. So this was an FGD among teachers of learners with disability. So even though sexuality education was integrated in several curriculum subjects, some teachers felt it was not their responsibility to teach SE. And I will show you an illustrative quote. Teachers tended to prioritize examinable SE content and did not pay much attention on the aspects on improving attitudes and skills or changes in behavior, because these are really soft skills that are rarely examinable. So these are some of the quotes from the teachers. In my class of senior 6, when I'm teaching a topic about family planning in CRE, Christian Religious Education, I do not feel comfortable because we are talking about sex. It's as if I'm encouraging them. This was a teacher who teaches religious studies. And I already talked about being examinable notes. So the teacher has had this to say: when the employer is a teacher of mathematics, they expect good grades in that subject. So a teacher goes to class and he puts more emphasis on that and may not really concentrate on the SE topics. Next. So among learners with disability, really, they had favorable attitudes regarding the impact or what sexuality education means to them. And the acquired knowledge and skills relates to what we have described before among learners without disability. And this is one of the quotes. They teach us that if you are born with a disability, you should not hate yourself. You should be happy with yourself, the way God created you. Know that just like other people, you are born to be like them and love yourself. So this is one of the quotes that show that they're improving their confidence through the sexuality education lessons. Next. Among the community members, and these include parents, religious leaders, they had perceptions, both supportive and some were opposed to certain content on SE. So they knew what constitutes of sexuality education. They described that their sources of knowledge were from lived experience and also the community health sensitization meetings. And they think that sexuality education is beneficial to learners, which could help them acquire skills to reduce on the high rates of pregnancy and early marriage or school dropout. And they perceived sexuality education to complement their own community efforts, and it bridges the gap between the community delivery, like the parent talks on sexuality education, and what the children acquire in schools. And we also have a quote below. If you have time, you can read it. Let's press the slide. Yes, so this quote, I may not read the whole of it, but it rests the fact that the community members believe that what the Ministry of Education has put forward as content for teaching is relevant for examination. And if the students are taught well, then they will get factual information and they will not rely on non-factual information from newspapers or television, apart from the program the previous presenter has given on focused messages from videos. So they can teach them family planning, but they should not emphasize that they should use it. But the community members also had some reservations on whether we should include the topic of family planning in sexuality education. They think sexuality education may encourage children to engage freely in sexual activity and without fear of pregnancy. And it may arouse curiosity to practice what they have learned. And they fear that if children are exposed to contraception at an early age, it may affect their future. And they think their attention from studies may be diverted and they will be preoccupied with sex. They also had concerns about the skills of teachers to deliver factual information on contraception, and they think that such inaccuracies may mislead students and lead to more problems. Some were saying they had religious beliefs that hindered them from using family planning. So this quote says it's fine, but for family planning methods, I would never want my child to know about it. Because if a child gets to know how it works, she will rush into sex since she knows she will not get pregnant. This was from a parent, FJD. Next, please. Some barriers for sexuality education that we witnessed in this study included a weak monitoring system and delay in approval of certain key policies, such as guidelines for implementation of the National Sexuality Education Framework, updating the National School Health Policy, and having a curriculum, a standardized curriculum for implementation of sexuality education, especially at primary level. We know there is one at secondary level, though the lockdown has impeded its implementation, but one at primary level is still lacking, so the teachers were not sure what reference material to use when they are teaching. And there were also inadequacies in teacher capacity and insufficient essential guides for delivery of sexuality education, including charts and other teaching aids and demonstration materials. There are attitudes or perceptions that sexuality education may lead to increased sexual activity among learners. So there was an inclination to emphasize abstinence, and without talking about the other broader prevention measures for teenage pregnancy or other STIs. And among learners with disability, they had an added challenge because of lack of skilled teachers to communicate sexuality education in the language that they understand. And they had a lot of diversity. The ones who wanted Braille, the ones who wanted sign language. So in an environment where you have to provide sexuality education to a diversity of learners, you need a teacher who is skilled in such aspects to make sure that they don't leave anyone behind. Next slide. Yes, this was a quote about the vision impairment, but you can go to the next because of time. Regarding the linkages between schools and health facilities in provision of SRH services, most schools reported having visits from health workers to help them deliver talks on sexual and reproductive health information. And these were mainly given on Child Health Days every April and October. And the services included immunization, deworming, and other health talks. In certain areas, health workers were invited to specifically conduct routine screening for pregnancy at least once a term among girls. And there were other avenues where the health workers interfaced with learners in the community through community talks organized by village health team members and other health workers. And also learners equipped with this information were able to access community health centers. We have a quote where one of the health workers is saying that learners come freely to access these services. Please move the slide and you can see the quote. So students, mostly boys, come for circumcision and individually pick condoms because they hear that circumcision prevents them from getting HIV. And for adolescent girls, they come for family planning methods, including pills and injectables. Next slide. You can move all of it down. Okay. So the challenges in accessing SRH services, these were really specific for the area where we collected data, but it could compare with other areas in Uganda. There were busy schedules for health workers because there were few, and there were inadequacies in health worker training, and the health workers also commented that they lacked illustration charts to communicate with adolescents. For instance, this quote about the busy schedule and the timing, it says we take our learners for treatment and other services such as counseling and guidance. You find when students go to health center, they take the whole day. Sometimes they will be understaffed. Therefore, we normally get other people to come and offer services from the schools themselves. So the learners also talked about the long distances that we have already mentioned that. But specifically for the learners with disability, these had particular challenges, especially in finding a health worker who can communicate to them. Most times when we say health-friendly services for learners with disability, people dwell on the physical disability, including having trunks. But these learners wanted to find a health worker who can interpret sign language and a health worker who can have a braille chart, for instance, to communicate with them. So this was a particular challenge for them when they go to health facilities. Next slide, please. So this is the final slide. So among our recommendations, we call upon the main actors and the ministry to fast-track approval and implementation of relevant policies or guidelines to support sexuality education delivery. The Ministry of Education needs to strengthen the monitoring systems for sexuality education delivery and to improve sexuality education and delivery and services, health services, especially for learners with disability. The teachers, through their training institutions, they need equipping and training in delivery of SE, including how to be comfortable with talking about these topics and how to control the class in case they get so excited. And there is need to also strengthen the school and health facility linkages. And from this study, we have learned that there is need to strengthen the multi-sectoral and multi-pronged approach in sexuality education delivery. This is being done at national level, but when we go to community level, district level, these services seem to be disjointed. The community should work together with the teachers, health workers, religious leaders to support delivery of sexuality education. I appreciate the contribution of the funders, the Ministry of Education and Sports, UNESCO, and the GMAT consultants who are doing the study, leading the study in the 5 other countries. Thank you for listening. Sorry I took so much time.
Thank you, Elizabeth. I allowed you more time because I thought that was an important study, quite detailed, so thank you very much. I hope the questions are coming on the chat. While they are coming, I would want to invite the next speaker, Dr. Agnes Napio, who is a lecturer in the Department of Public Health, Faculty of Health Services, Busetema University. Welcome, Agnes. I hope you will be briefer than the previous presenter.
Thank you very much. I've been given the most difficult time in which to present, but I'll try to be as brief as my data allows me. Yes, today I'm tasked to present to you work that we have done between 2018 and 2020, and particularly this paper or research work is entitled Exclusive Breastfeeding Among HIV-Exposed Infants from Birth to 14 Weeks of Life in Northern Uganda. And this was a prospective study, a prospective cohort study that we did in the time period that I have mentioned. It is collaborative work between Makerere University, the University of Bergen in Norway, and Busitema University. Yes. Just continue. We have published this work. We have published this work in the Global Health Action Journal among the Taylor and Francis group of journals, and that is our publication. Just a few facts to know about breastfeeding. It's common fact that babies must breastfeed in the first 6 months of life without anything else being introduced, including water, solid food, with the exception of medicines. In this case, when we talk about HIV-exposed infants who are babies born to HIV-infected women, with the exception of the nevirapine syrup and other medicines that are being introduced to them. And it is also a common fact, evidence shows that HIV-exposed infants are actually prone to opportunistic infections, as well as malnutrition and even death. And evidence also shows that breastfeeding in itself is protective in a way that it lowers the risk of incidence and death from opportunistic infections. It also reduces the risk of hospitalization from infections, and also it improves growth and development. This is not only for HIV-exposed infants, but also for neonates or infants in general. However, when mixed feeding is introduced where you have a baby taking other solids and liquids in the first 6 months of life, evidence also shows that this actually increases HIV transmission by 4-fold. And it is also common knowledge in science that breast milk actually contains constituents that are very important to the baby in development of their immune system and also in protection against other pathogens, including bacteria and viruses. And when a mother that is HIV infected is breastfeeding, they must be adherent to their antiretroviral therapy during their breastfeeding period to prevent HIV transmission. However, we continue to see that the rates of exclusive breastfeeding among HIV-exposed infants is low. But this rate varies across different countries, and we really want to understand why these rates are low. So that is why we decided to determine the incidence, the trend, and risk factors for non-exclusive breastfeeding among HIV-exposed infants in their first 14 weeks of life. We did this study in Lira, in northern Uganda, particularly in Lira Regional Referral Hospital. We know that it's a regional referral hospital in northern Uganda. I don't need to go through this. And we did it at the PMTCT clinic. And just maybe to understand this setting, this PMTCT clinic offers free care to HIV-infected pregnant women until the babies are 6 weeks of age, at which point they are discharged to what we call the early infant diagnosis clinic to be tested for HIV. So we looked at a single cohort of HIV-infected pregnant women that we followed up from antenatal to the time they delivered their babies, that is at birth, to 6 weeks postpartum and at 14 weeks postpartum. Yes, so these participants actually consented to participating in this study, and we recruited them consecutively until we achieved the desired sample size. We only recruited those that were 20 weeks or more pregnant, whether newly initiated onto antiretroviral therapy or already established into HIV care. However, for those whose partners declined participation, we did not include them in the study. We made sure that their visits coincided with the normal visits for the mother, her routine visits for the clinic or immunization for the baby, so that they do not have to get extra transportation costs to come just because of the study. So there are different reasons as to why women dropped off the study, some of which included if the partner refused, and there were quite a number of them. There were 21, we did not include them, but also if a mother was imprisoned, and also if their baby died. And we looked at a number of outcomes in this cohort, but the one that I'm concentrating on today is the one of exclusive breastfeeding. So what did we find? Okay. So what did we find in our cohort analysis? We relied on Stata to analyze the data we collected, and we relied on Poisson regression models. So when we look at that trend, I'm just talking about the most important results. We realized that the exclusive breastfeeding, the proportion of babies that were exclusively breastfeeding reduced as the babies increased in age. At birth, there's something we call prelacto feeding, where babies are introduced to other feeds other than breast milk. We found that 12.7 babies actually were given other things, which included honey, water. That was at birth. And then at 6 weeks, we found that actually about 22.5% of babies were not exclusively breastfeeding. And by the time they were 14 weeks of age, about 50% were actually not exclusively breastfeeding. And we all know what the danger of that is. If a baby is mixed feeding, their chance or risk of acquiring HIV from their mother is very high. So by the time we are having almost 50% of babies at 14 weeks before 6 months mixed feeding, then we know where we are headed. So we try to look at what feeds these mothers tend to give their babies at the different age points. We did not look at the feeds these babies get at birth, but we went ahead to look at the feeds they get at 6 weeks and 14 weeks other than breast milk. And the commonest was honey. And when we probed a bit more, these ladies informed us that actually they believe that honey helps the baby, protects the baby from false teeth as well as colic pain. And other studies have reported the same. Studies that have been done in northern Uganda and are studying breastfeeding have reported a similar finding. And then there are mothers that will give water, cow's milk, soup, porridge. Very few or none at all rely on the infant formula. So we wanted to understand what predictors are there. When I say predictors, any risk factors for non-exclusive breastfeeding. We relied on a logistic regression to identify these risk factors. And babies that were most likely not to exclusively breastfeed were those that were born to women that were in a higher socioeconomic status. We tried to calculate socioeconomic status. We relied on a particular technique called the principal component analysis. And in our data, we find that women that belong to a high socioeconomic strata are the ones that are employed. So a plausible explanation for this would be the work demands that come along with being employed and pressures as well. So they have to return to work very quickly and cannot exclusively breastfeed their babies. And also women or babies that were born to women whose births had not been supervised by a health worker, those babies were likely not to exclusively breastfeed. So if a mother gives birth in the absence of a health worker, it means they have given birth out of the hospital. Maybe at home, maybe on the roadside, or at the traditional birth attendant. And of course, they miss out on the benefits of interfacing with a health worker who can give continuous infant feeding counseling. And in this data set, in this cohort, these women that actually didn't have a health worker when they were giving birth were actually women who delivered out of the hospital. And there's a high proportion of those in northern Uganda. And the other risk factor was an infant being born to a mother who herself does not adhere to their antiretroviral therapy during pregnancy. So if a mother cannot adhere to their antiretroviral therapy, how then can they support their baby to adhere? Or how then can they support their baby to exclusively breastfeed as well? So in conclusion, we actually recommend that antiretroviral adherence and infant feeding counseling to be emphasized not only in the health setting, healthcare setting, but in diverse settings, including the workplaces. And I think that is a big theme of this conference. We need to give HIV support in the workplace. And that is one recommendation that this study is actually bringing out because of one particular finding we had. And we go ahead to combine our finding with the theme of the conference and go ahead to really recommend that the workplace be included in the HIV response. Yes. What else? Yeah, of course, we thank our study participants, but mainly we thank the funders who are NORAHED and the Survival Plus project. This team was very key in implementing this study, and yeah, thank you to them. Thank you very much. I think I didn't take...
Thank you, Dr. Napio. That's excellent study results. Do we have any questions online or in the chat box? Is that speaker here? Yes. Agabama, please come and make your presentation.
Protocol observed. Good afternoon. I'm by the name of Agawa Mark Leonard. I'm the Monitoring and Evaluation Officer at Uganda Young Positives. Our mission as an organization is to promote a better quality of life among young positives and to reduce the amount of HIV infections among the young people as a whole in Uganda. I'm here to present HIV among children, adolescents, and young people. The background: Uganda Young Positive, with the support from UNAIDS, had a project called Giving Hope to the young people living with HIV in the informal sector. This project aimed at helping young people to adhere on art and acquire knowledge for HIV treatment, plus sexual reproductive health and GBV or gender-based violence, so as to cover the knowledge gaps for the HIV treatment and boost their adherence. The project was also to support the young people living with HIV in the informal sector to revamp their businesses due to the uncounted effects of the COVID-19 lockdown measures, which sabotaged their standards of living and access to treatment. Some of the methodology we use is we identified young people who were unable to get their art drug refills, so we conducted a door-to-door delivery of the art refill to those young people living with HIV, and take those to the health facilities for the routine viral load testing. We trained young people living with HIV with entrepreneurship skills, where they gain knowledge of understanding of management, planning, bookkeeping, and how to raise money for their businesses. We also sensitized young people living with HIV in the informal sector on COVID-19, the dangers and the effects, on the HIV treatment literacy, the sexual reproductive health information and services, and gender-based violence through the peer-to-peer community engagements and media presentations on the HIV sensitization. Through the Giving Hope project, we managed to achieve the following results. 100 of the young people living with HIV in the informal sector gained knowledge and understanding of the business planning and management, bookkeeping, and saving, or in how to invest, which as a result led to more profit accumulation in the business, in their businesses. Through the program of the door-to-door delivery of the ad program, we managed to reach 96 young people through taking them to their facility visit for viral load and physical delivery for the ad drug refills. 95% of the targeted young people living with HIV in the informal sector are now progressive since their businesses have been revamped, and now they can afford some of their personal needs and necessities and increase in stock, and form also other side jobs to improve on their lifestyle. Young people understood the importance of the treatment literacy and the dangers of the COVID-19 and how to overcome with them. They were given access to sexual reproductive health information and services, which in the end motivated them to demand more of the viral load tests and speak up for their health rights and act also as Uganda Young Positive ambassadors towards the general of the gender-based violence. Some of the discussions we came out is we should ensure or bring out more projects like this, or the youth initiative programs such, so as to help the young people who are living positive in the informal sector more out and reduce the amount of idleness or the amount of criminal rates that will entail due to the COVID-19 lockdown. Recommendations. There is a need, a desired need, to reach out for more out of the Uganda young people living with HIV in the informal sector with knowledge and vocational skills to promote creativity and more talent development that enables them to acquire long-term benefits and live a productive life. Having met our targets of the young people living with HIV in the informal sector, we have the confidence that such products or such projects or such initiatives should be scaled up to benefit more of the young people living in the informal sector, not only in Kampala, but also across the whole country. So I call upon all membership, all partnerships, and stakeholders, the government, and the international or the local donors, to hold up and put more youth initiative programs for the young people living with HIV in the formal sector. As I conclude, I would like to thank the Uganda AIDS Commission and all its implementing partners. Thank you for this opportunity, and I encourage you that you often address us more. Amen.
Okay, thank you, Mr. Mark Agawa, for your presentation. I think that was the last presenter. I want to see if there are any online questions. Are there any online questions, comments? No? Okay.
We haven't received any yet.
Okay. Okay, great. So there are no questions or comments. I think these were clear presentations. And I want to, you have one? Okay, go ahead, Dr. Jane.
Okay, good afternoon once again. Thank you all for the presentations, my co-presenters. I had a few for Dr. Napier. Agnes, she's still around? Okay. I was just wondering why the time point, 14 weeks, why 14 weeks? We know it could have gone maybe to 6 months, sorry, the expected exclusive breastfeeding period. Just wondering why 14 weeks? And then I was wondering if you had any outcomes regarding the testing at 6 weeks. What proportion of those maybe who did any turn positive, those who were exclusively breastfed at that time versus the non-exclusively breastfed? And I was thinking, well, of course, this was dependent on the available funds, but I think it would be good to follow up all that cohort to the end of the cascade, 24 months, and see what the outcomes in the end are for that cohort. Yeah, the last one, Uganda young people, I think I might have missed it. I was just wondering what their reach is, where they are found, and what their catchment area is. Thank you very much.
Thank you for the brilliant questions. I would like to answer the last question first. Yes, at 6 weeks, we looked out for the DNA PCR results, and we found 4 out of 172 babies at 6 weeks had actually become positive. That's roughly almost 1%. And we were still looking at the very cohort. We want to look at it up to 24 months. And the other question was, why didn't we go till 6 months? At that time, the available funds could only take us till 14 weeks, but we are still analyzing the very cohort. And more questions were asked about breastfeeding, which haven't actually been analyzed, and that is probably another addition to this for a later time. Yes.
There is another question, I think Dr. Naka was asked to young people.
The Uganda young people, I was just wondering what your reach is, your catchment area basically. Like when you say door-to-door drug delivery, which area was it? How did you identify these young people? Yeah.
Can I ask? Sorry, I have a concern to the film, the guy who made the presentation around the movie. You said one of the movie was approved by Uganda AIDS Commission, right? Why not others movies approved by Uganda? Why only one was approved by Uganda AIDS Commission? And I also wanted to understand, you said you produce movies, then show them to the young persons, right? Why not produce the movies with the young persons so that they can learn how to make these movies, how to produce these movies? And lastly, how do you deal with the perception that actually movies are more destroying than building the young persons? Because that's what it is in my community. Ebibanda bya film byonona bwononyi baana. They just spoil our children rather than helping them to grow.
Okay, so 2 questions, but let just a minute. He's answering the question first.
Thank you, Doctor, for that question. As Uganda Young Positive, we are a community-based organization for the young people living with HIV, and we deal with
One of the criteria we use is the peer-to-peer engagement in our communities, where peers go out in different communities to test and to assist those who are HIV positive and need assistance. So that's the way we came out to that idea and identified those who are unable to address or to pick up more art refills from their facilities. Thank you.
Okay, about the films, yes, go ahead.
Thank you, Supercharger, for the questions. I'm going to answer the one that I've captured very clear. Why 1 out of 10 films being only cleared by Uganda AIDS Commission? One, when we are starting to produce this film content, it was hard for us. We struggled to produce that one first movie. And when we produced it, we submitted to Uganda AIDS Commission for clearance. Luckily enough, it was cleared. Then the next 9, it took a short time to produce, and we are in process with the Uganda AIDS Commission for them to be cleared. Hopefully they will clear. Thank you. I would capture another question, then another question from you, sir. The second question was saying what? Let me first answer your questions. 2 remaining.
So you have produced so far 2 movies, not 10.
I said 10 movies, 1 cleared.
1 cleared, the 9 are not cleared. But I thought, okay, like it's like a piece of advice to your team. I think it will be better in future to make a composition. You make a plot of the movie, take that plot to Uganda AIDS Commission for clearance before you start production, isn't it? The clear draft, not a produced product. Because when you take a produced product for clearance, you are likely to have a problem. They might refuse something which you have already spent money on. Yeah? So it's like an advice. It's better you take a draft document, like this is my a script, you call it a script. It's better you take a script for approval. And then the last question was around the perception of community with Uganda film. How do you deal with it? Because my child telling me daddy ngina mchibanda kusoma. How do you deal with that in your community?
Thank you. I captured that first. Thank you. The films we do, I was very clear. We do educative and preventive. Actually, I do what you do. Only that I do in film, you do in music. So, educative films are not pornographic content. Actually, what we are doing a content to confront the bad content on social media. Our young people, what? Consume. Then lastly, we don't take our movies to Bibanda film. We use the educational channels, schools, to make sure that these people can have alternative, apart from music and sport and Facebook content, can have another provocating content that can bring in knowledge and skill to make an informed decision about the choices they make. That's our war. Thank you, Supercharger. Luckily enough, I know the struggle we go through to record a video. You also know how you're recording a video for music. Thank you.
Okay, Dan, next.
Thank you, Chair. My question, I think, goes to Elizabeth regarding the sexuality education study. And I think in her presentation, she said they engaged learners, teachers, communities, and policy level. So I wanted some clarification at policy level. Who did you engage? And your feedback from the community engagement is so positive. The community appeared like it was supporting sexuality education because it's a reliable source of accurate information compared to the media and radio and that kind of thing. But that is contrary to what we know. It's actually the community, the politicians, the church leaders. So who did you really engage in at community level? And how generalizable? You, because of COVID limitations, you are in one area, I guess you are in one sub-county or something. How do you think generalizable, how generalizable are these findings? We shouldn't start drumming when actually, and we end up in later, and the community has totally different perceptions and they chase us with sticks.
Elizabeth, are you there? Can you respond to that?
Yes. Thank you so much for your question. You had 3 questions. One is, who did we engage at policy level? Without giving names, we had Ministry of Education and Sports at policy level. So we had the Department of Gender, the Department of HIV and Counseling, and then we had the National Curriculum Development Center and the Uganda National Examination Board, because we wanted to see whether the content is actually being examinable. So we had a variety of those from the Ministry of Education. We also had Ministry of Health at policy level. We had from the Adolescent Health Division. And then the rest were from southwestern Uganda, the health workers at the different levels, and also the district education officials. The other question was about why the positive attitude. I think if you ask the right question, then you'll get the right response. The problem people asking about sexuality education do not ask the question in a whole package. So our entry was, what do you perceive as the problem young people face in accessing information? And from there, then you tease out what could the school do, what are they doing now, and they were receptive. So the problem, we have to formulate the right way to ask the questions on sexuality. But if you go to the community and you ask a direct question, do you think your child should be taught about sex? Do you think your child should be told about condoms? If you don't use a problem-based approach, then people will always be defensive and reject. So I think I cannot generalize results, but I think if we use the same approach in different communities which are already facing problems of young people, then we can generate probably related messages, because we have seen, especially in this COVID, how the absence of school-based learning on SRH has contributed to excessive teenage pregnancies and other related challenges among young people. So I think it's the way we pose the question that will bring the answers. So our respondents included parents themselves, the teachers, the religious leaders, the police, and they were all affirming the need to give positive messages on how to improve SRH behavior among young people. I think I've answered your questions, and I can give you my contact if you want more information about the study. Thank you.
Yes, thank you. Thank you, Elizabeth. Next is the Director General, Uganda AIDS Commission, Dr. Nelson Musoba. Yeah.
Thank you, Session Chair. Chair, I have a comment and then a question to Dr. Agnes Napio. The comment is to acknowledge and appreciate the colleagues for the high quality research. I was particularly, I was very interested in all of them because they touched very unique areas. The study on sexuality education by Dr. Elizabeth Kemigisha, for instance, touched a number of areas where we've had different perceptions, and she's sharing real experiences. As a matter of fact, I would like a follow-up, because the sexuality education framework as a policy was produced by the Ministry of Education. We worked with them, but the rollout has not been as easy as we had anticipated because of some of this. So it's exciting to see that a scientist has gone ahead, has talked to different stakeholders, and is giving us perspectives based on science and evidence. And for me, this is very exciting. I would like to invite Dr. Kemingisha to join us so that we continue to engage with these other stakeholders, Minister of Education, with the faith-based leaders, with the communities, to see how we can reverse some of those sexuality, perceptions around sexuality, because it touched exactly what a number of perceptions have been. Then for Dr. Agnes Napio, you talked about, when you're talking about exclusive breastfeeding, you talked about the aspect of the workplace being associated with, with either introducing mixed feeds early or probably getting off from exclusive breastfeeding and introducing other things. What was the role of stigma in this? Because I tried to listen, but I'm not sure I heard you say something. And yet again, we know anecdotally that stigma is playing a role and affecting mothers, especially within the community, from the mother-in-law, from the spouses. Sometimes the family members do not necessarily know the HIV status of the breastfeeding mother, and they are putting her under pressure to do certain things, and it leads to those. So what was your finding on that? And your study was also quite complementary to what Jane Nakawesi did. And my general question broadly is, what do we need to do while following up children in the communities to address, these issues and mitigate against seroconversion in newborn infants, as much as it's such a broad question. But I hope that your study was able to identify and touch on what some of the things might be. Thank you, Chair.
Yes, thank you very much for your question. It indeed is true that stigma is a key role player when it comes to HIV response. In our data set, we had some questions evolving around stigma. And just like I mentioned earlier, it is a purely quantitative study. And when we ran the analysis and tried to fit the regression models, it's either fortunate or unfortunate to say that actually stigma wasn't a statistically significant risk factor in this case. Yeah.
Maybe I can add just a little bit of that from the programmatic now side, working with the Ministry of Health team. I think, like you said, her study, or my study, I don't know, whichever, was complementary, because she said those mothers who had not attended skilled care were more likely to, do non-exclusive breastfeeding. And I also found out that those mothers who didn't have skilled care were more likely to have maybe positive infants. So attending to that aspect of having mothers attend skilled birth attendance is very key. Bringing services closer to the community, which we are trying to do on the side of the HIV program, I think is very important. But another aspect she pointed out is that still those who don't attend skilled birth attendance are more likely to non-exclusively breastfeed and maybe eventually turn positive. So patient literacy is also key. Maybe we need to extend it to those even who do not attend skilled birth attendance. We even need to involve the communities, but also maybe the traditional birth attendants where these mothers are likely to go. Thank you.
Yes, Supercharger, go ahead.
A quick one. I think I confused the presentation, but I picked an interest whereby, either doctor, you reported that 77 out of the 125 children tested had mother as caregivers. And I was wondering, did you notice differences in these kids, the characteristics of these kids, those who had mothers and those who did have mothers? And what did inform you as a researcher?
Thank you, Supercharger. I incidentally note, because this was basically descriptive, we just wanted to know who are these children, so we didn't go ahead to do a deeper analysis. But there's another study we did, maybe we'll present at another forum, where we compared those with biological caregivers versus other caregivers, and there was no statistical difference. This was to do with viral suppression, actually, but for this particular study, no.
Thank you.
Yes, please go ahead. Young positive, I think.
Thank you very much, Session Chair. Mine is a compliment. My name is Kraish Muviru. I work with and for the Uganda Young Positives as the team leader. I want to acknowledge all the presenters, but most importantly, acknowledge my colleague, Mr. Mark Agava. Mark Agava explicitly shared the work that we did immediately after the first lockdown, and it transformed the lives of young people living with HIV, especially those in the informal sector. And I want to applaud him particularly because he was one of the beneficiaries in that program, and because of the motivation that he got therein, he was also motivated to come and join us, and we quickly dived him into our M&E department, and currently, as we speak, Mr. Mark Agava is our M&E officer. So I'm very sure that the country director of UNAIDS, Dr. Josham, and other development partners in this room are very confident and happy to have such products reach at the level of presenting an abstract in such a meeting. I beg to compliment and submit. Thank you, Chair.
Yeah, thank you for those compliments. I want to join you in appreciating his work and other work, and indeed, I think Dr. Jen Nakawesi asked a question, what is your reach? I think the implication of that question was that, can you scale it up? Please, we encourage you to scale it up and so that it reaches many more young people, because clearly from what you have done, they have benefited socioeconomically, and we think that if that could spread to more young people in the country, that could cause some good socio-economic transformation. So thank you very much for that work. Yes, please, I cannot see at the back. Please come and share a comment or question.
Thank you, Chair, and thank you, the presenters. Mine is to Ahawe. You had a target of reducing the infections about 3%, something like that. I just wanted to know what guided that target, how did you come to it, and how are you going to measure the attainment of that target? Thank you.
Thank you, brother. We derived to that target by adding up the percentages of young people living with HIV. And we looked at how are these young people getting infections. Basically, young people, not children, were on a bigger percentage acquiring AIDS through risky sexual behaviors that wanted to be really dealt with strongly. And the project being educational, we target to educate with much emphasis on on creating like knowledge and skills, projecting both sides to give someone or to give a young person a choice to make a decision. That's where our strength is. Because we may not tell why are these young people behaving, risk life, even when messages are being passed on. So our role basically is to educate those teenagers and young people. And mostly when you look at the children of 8 years, you prepare their minds to make, making a decision in young people is the most important tool. And the people who stopped the sexuality education framework, it is regrettable, because even the younger, the better to prepare someone's mind to make a decision earlier before. So, and in calculating the decisions made and the impact created, you cannot be exact, but you project. But the most important thing is you to educate, equip knowledge. Other things lies in the hands of either individual or God. We cannot be specific in statistical when it comes to decision making among young people. But my brother, your question was interesting. We added the 0.5% for children. Those are, I think, the breastfeeding, those toddlers. Then the 6.7 for young girls, that composes a bigger percentage. Young girls are at more risk. I don't know socioeconomic why, but they are more risk than young boys who compose 4.7%. When we added up those, and our strength was the teenagers who indulge in risk sexual behaviors, they could really be taught how to avoid. That's where we came up with emphasis, like we can do something on this. So education is very paramount, and we have seen people talking to young people day by day. We needed something practical other than pulpit preaching. You extend knowledge, then you let a learner make a decision. Sometimes learning is not forceful, my brother, but we should not sit back until our young people keep, acquiring. We could do something. Actually, we could do something bigger. Because in the previous activities we did, young people put up what they have learned in a short video that was created by Uganda's Commission. They said, it is good, we have learned this. Some things may sound not good to people, but if I can quote what I remember, they talked of faithful. Those are young people who were saying, meaning that they are sexually active. They talked of, I'm lucky, who stopped the sexuality framework are not here, but they talked of using a condom. And that content, we did not project it in our movie, but it's like someone's mind gone ahead to say that at least to acquire this, I would use this. So we realized that educating really has a lot of potential. Thank you, my brother. Okay. And a quick one. When you are teaching young people, you don't know who will fail and who will pass. So that's why we did not rise up our expectation higher to 12%. That's 100%. We know that some people pass and some people fail in the general context of education. And you cannot ask a teacher why Peter failed. You cannot tell why. But the role of the teacher, the role of the preacher, and the role of the parent is to teach. Teaching and teaching. When you teach, you have done, I have done our duty. Thank you, my brother.
Okay, thank you very much. I think the gentleman's question is appreciating your goal to reduce infections among young people, and he also appreciates that you need to perhaps consult more or learn more how you're going to measure that goal, and it is to encourage you to think about how you will achieve that goal, how you measure it. Not now. I think we are getting late. If I don't see any other questions, Jen, do you have another question? Yeah. I think this has been a rich discussion, very good presentations, excellent scientific work. I want to applaud the Uganda AIDS Commission for this effort. Honestly, this is work that would have been out there without us ever knowing that the work is out there, and I want to thank you for this. So, with those few words, I would like to adjourn the meeting to tomorrow. I think we'll continue from where we have ended tomorrow morning. Thank you very much. Meeting adjourned.
Recording in progress.